A very warm welcome to our vector control community members in Asia Pacific, and in fact from many other parts of the world that either have already joined or will be joining soon. Good number of people, very good number of people that have registered for the event. These events where we can share experience and knowledge are always enjoyable events. So on behalf of APMEN, I'd like to thank you for setting aside time to be part of our APMEN Vector Control Working Group annual conference. Just a reminder again, as you heard a few seconds ago, this meeting will be recorded and uploaded onto our apmen.org website. So this is day 3 of our annual conference, the final day, and day 1 was last week Tuesday. It was devoted to issues relating to vector surveillance and control capacity shortfalls, and a look at some of the training courses that are available for National Malaria Control Program staff to attend. Kind of a scattershot of look at different courses that are available for capacity strengthening. We had 5 short presentations outlining some of the training courses available to vector biologists, and then followed by a breakout group to discuss additional training gaps and needs that we should be looking at filling by way of different interventions and courses online or face-to-face. Sorry, I'm having problems with the screen here again. I'm sorry. So day 2, which was on Thursday, was devoted to outdoor biting challenges and vector control tools. And we had 5 excellent presentations to set the scene. Most of them state-of-the-art tools for outdoor control of malaria vectors, followed by a breakout discussion on research needs for outdoor biting. So today, there's no specific thematic focus for our various presentations. Instead, we have some very interesting updates on important issues or technologies. And I'm absolutely convinced we're going to enjoy them. A wonderful range of presentations on very different topics. There's no breakout group discussion, just the 5 presentations, followed by a Q&A session, question and answers. And then we'll have a short closing message before waiting another year for the next annual conference. So on behalf of all of us, I'd like to thank our expert presenters for their time to share their experience with us. And to our respected audience members, if you have a question you would like to pose to our speakers, please put them in the chat box. We'll collect those, harvest those questions, and then pose them to the speakers at the end of the session. So we're not going to give question sessions between the presentations. We'll save all the questions for right at the end, because some of the questions may relate to across different presentations, and it's good to have all the questions together. If you have a particular speaker in mind to answer your question, please put the name before the question. For example, Dr. Mukhtar, and then put your question in the chat box. Our first presentation is by Dr. Leosora Makita, who's a program manager for the Malaria and Vector-Borne Disease Control Division in Papua New Guinea. It's a pleasure and an honor to have you with us today, Dr. Makita. We know you interrupted an important meeting to give us your presentation, and we thank you for that. Dr. Makita is going to talk on the subject of Papua New Guinea malaria status and vector control challenges. So over to you, Dr. Makita. Thank you. You're on mute, Dr. Makita.
Can you hear me now?
Can hear you clearly, Dr. Makita. If you want to share screen, I think we're ready for you.
Yeah, I just sent the presentation across. Are you able to screen it from your end?
Ah, so you'd like us to share it. Okay, no problem. Would you mind doing that, Wulan?
Sure, will do.
Thank you. Thank you.
Okay, it's ready.
Okay, thank you very much. First of all, let me thank you for inviting me to this meeting, and also to get me to do a briefing of the country's national program. Let me thank you all very much for that. What I will do is I will go through, not in very much detail. I would have wanted to do that, but I thought that in the interest of many of us who have issues with timing and all that, I thought I'll just quickly run down through the situation we are in at the moment in Papua New Guinea. Now, this slide is actually showing us the trend over the last 21 years. This is the trend that we see in terms of the malaria program. While we've been doing quite well, some point down the line, we've actually not done so well, probably because of other issues such as COVID and other pressing issues. But this is basically the trends that we see in the country now, and these are real numbers. They're not percentages. They're actual numbers of cases that we've seen over the years. The next one. Sorry, can we have the next slide?
Yes, is.
Yeah, I'm also again trying to show you the reported suspected case of malaria between 2000 and 21. It's a similar graph to the one I showed in the first screen. But this is what the picture looks like for the country. And of course, all of us knowing that about 80% of the cases in this region come from Papua New Guinea. Now, it's quite understandable why we have this kind of trends. And on your right, you can actually see those that were tested and confirmed, and those clinically diagnosed. The red indicates the diagnosed and confirmed cases. The green shows the total suspected cases, and the blue is the clinical cases. It is quite an interesting graph because what we are seeing is since 2013, our confirmation of cases have been increasing, probably because of the fact that we had started distributing rapid diagnostic tests. And probably people are more using the tests rather than diagnosing clinically. So that, in effect, is a good sign for the program because we're sort of getting those clinical cases down in the country and increasing those confirmed cases either by RDT or microscopy. Next slide. This again in another way, the graph on the left is trying to show us the clinical versus the confirmed cases in Papua New Guinea. So it's very clear we have been reducing the number of clinical cases and getting more into confirming all the cases, well, most of the cases that we see in facilities. And if you go to each province, we got about 19 provinces. You know, it's a different picture. I mean, it's not very clear here, but this kind of graph also shows you where our burdens are in the country actually. So you can see that certain parts of the country have higher burdens than other parts of the country. This is for a 3-year period from 2019 to 2021. So this is the kind of picture you would see if you look at the middle part. That is basically the highlands areas where the cases are very, very low. And then if you look at the front part of the graph, that is the southern region, that is the south coast. But the other 2 regions have got quite a high burden in the provinces themselves. Okay, next one. Now, when we come to the deaths, these figures are taken from our national information system. That's the only information system that we use to gather data. So this is again not. It is actual deaths, not put in terms of percentages. So this is a picture of the reducing trends in the deaths, and obviously we know that we do have a lot of deaths in the rural areas. This is not accounted for in this graph. This graph accounts for deaths that are recorded in health facilities. So those that are reported, or those that die in rural areas are not reported here. So it is more or less an underestimate of the deaths probably, but this is the kind of picture we see in facilities. Well, the other one just shows you by province, but we can move on. I think let's go to the next graph. This is the picture. It shows the malaria incidence from 2000 to 2021 and the mortality from 2000 to 2021. So our trends have been reducing over the years. We need to maintain this or even further improve on the trends that we've been able to achieve. Next one. Now this is again on your left is showing you the inpatients. That's from 2021, 2000 to 2021. You can see that the inpatients have also reduced quite substantially. We just need to improve that a lot more so that we do not have too many inpatients. And of course, that just the other graph tries to compare it with the deaths of inpatients. So as we all know, I think death of inpatients is an indication of management of malaria cases. So we are quite serious about looking at trying to avoid deaths, especially in inpatients, so that it kind of reflects on how cases are managed by clinicians. Okay, next one. Okay, these are just clinical and confirmed malaria deaths. So the orange indicates the confirmed malaria deaths. The blue is the clinical malaria deaths. And the line is the percentage of confirmed malaria deaths among all malaria deaths. So this is the kind of picture we see in terms of clinical and confirmed malaria deaths. And the graph on the right side is trying to show us the case fatality rates in inpatients. So next one, I think. Let me not dwell on this one. Let's move on. If people got time, they can go through it and then see. See this. These are actually graphs that were supposed to measure what's happening in provinces, in the 19 provinces that we have. But it's a little bit crowded, and if somebody has the time to sit down, I think you can look at it and see the trends in each of the provinces. Okay, can we move on? Okay, let's come to the program. I think that a bit of statistics I was giving is just to indicate to all of us, how serious our situation is, which makes it sometimes difficult for us to look at 2030, because we continuously get cases. Transmission is still very, very high in certain areas, and the systems are not in place to be able to deal with these inconsistencies in terms of the health services systems and the resourcing systems. We dreamed up a very, very ambitious vision that was to have a malaria-free Papua New Guinea in 2030, and that's very, very ambitious. I know that people will say, how can Papua New Guinea achieve this when they are in such a situation? So, but in any case, that was the vision we set. And the mission is to improve, transform, and provide quality malaria prevention and case management services, which is based on the health system, health services that are provided throughout the country. And I think our goals have been to reduce morbidity by 63%, but that is also an ambitious plan. We can work towards it, but whether we achieve is going to be another issue. Reduce malaria mortality by 90%. We can, I believe that this is something that can be achieved if we have a good health system that can be able to manage patients properly. And we've been thinking about eliminating malaria in one of our regions, one of the provinces, like you call it subnational elimination. This particular province is the autonomous region of Bougainville, which has very low incidences of malaria. So we feel that it is possible we can achieve this goal. Okay, can we move on? Next one. Here I try to list down the objectives we have. So you can see that our major objective is dealing with vector control and personal protection. I think the LLIN program in Papua New Guinea is quite, it's quite big. We've been able to reach about 98% of the population. Our problem is getting people to be able to use the mosquito nets that they have access to. And that is a bigger challenge for the program itself. It's not getting the nets out there, it is getting people to use it. And behavior change communication, sorry, case management. I think that is a very important aspect. If we have to see reduction in deaths, this is where we need to improve a lot on with the case management. Behavior change communication. Yes, I'm talking about behavior change, not only for communities, behavior change for healthcare givers. You come with the situation sometimes where healthcare givers are not prepared to change into new ways of doing business. And so, we try to place this not only for communities, but also for the health workers ourselves. And surveillance and response is quite a huge area. We've got some surveillance going on, but there needs to be more done to establish a good surveillance system. Otherwise, the program cannot see where it is going and how effective our programs are. And the enabling environment, which looks at, like resourcing by governments, HR issues, the health system issues. So we have to be working in an enabling environment to be able to achieve or to be able to produce what we say we want to produce. If that is non-existent, it probably may not happen at all. Next, please. Now, these are the elimination objectives we set a couple of years ago. And that was since 2011. We were looking at the national API and the national mortality. So whether this, the figures for the annual parasite incidence and malaria mortality presented here were actually modeled in around 2019, but we've cut this one just so that if we do go through another process of modeling, this might change. Okay, next. I will not go through all the activities that the program tries to do, but you can quite clearly see that net distribution is one of our biggest. Case management, ensuring availability of commodities, uh, training, and other normal issues that that the program requires for to have people trained and be able to do much of the work that needs to be done. And one of the key things we are continuing to do is monitoring insecticide resistance. And hopefully we're once again looking at IRS to complement the distribution of mosquito nets, or we'd like to call it focal spraying, where situations allow us to go in and then do a quick spray. Next, please. I think I've gone through this. If we can just move on. Okay, these are the priorities that we set to immediately augment in intensive malaria prevention and case management services. And we'd like to target populations that are in remote areas with no access to health services. We'd like to be able to support capacity development for staff involved in malaria-related activities. I think many of you probably know or don't know. Our health system is organized in a way that you have what they call provincial health authorities, which are basically responsible for delivery of health services. This does not happen from the headquarters down. So it is through the provincial health authorities that you have to go through, because they look after the staff, they look after the money, they look after everything more or less. So try into that kind of system is quite challenging in itself. Of course, burden reduction, that is something we definitely have to do. Vivax has been an issue for us. We are still looking at how we would like to handle the issue of Vivax. We don't even understand the prevalence of G6PD deficiency here. And it has become quite challenging for us to even change our treatment protocol for Vivax. So we're just waiting some more information to be able to look at how best we can address the issue of Vivax. And of course, if we're able to raise the profile of malaria, like COVID and everything else, maybe we can succeed a lot better and faster. Next one, please. Okay, the provinces in the country continue to provide the essential packages of vector control. So they're actually working with our partners to be able to deliver mosquito nets to their populations. We have a very serious issue with capacity at the provincial level. A while ago, I said, the PHAs are responsible for service delivery. But when they do not have the capacity to be able to deliver, it becomes even more difficult. So that is the way you know, we try to handle how we can handle the capacity at provincial levels. And hopefully we can be able to pick up those areas with very high burdens and slowly go through and reduce the burdens they have in each of the high burden areas. Next, please. Okay, our vector control program is implemented in a rolling way every 3 years. So every 3 years, a province that had its nets distributed will be redistributed after 3 years. And then we also try to do the continuous LLIN distribution, and that is especially to mothers and to children who come down ill with malaria. We hope to reintroduce IRS, but that is another ball game. It's quite a costly exercise, and it requires a lot of expertise. And we need to look at other ways of supplementing the current vector control strategies we have. You know, like if there is a way to be able to complement net distribution, that would make a lot of sense. And also in this space, we also try to get our Institute of Medical Research involved in looking at new vector control tools that can be utilized by the program itself. Okay, next. Yeah, case management, I believe, is straightforward. It is something that is very much dependent on the general health services. But the program's role here comes into play as us trying to ensure that there are adequate commodities available, like treatment, tests, and so that we don't have any stockouts. And that has quite successfully been done. And you know, many facilities that are visited almost once a quarter. So during those visits, we are taking drugs with us. We estimate the number of drugs and tests they would have used. And then we try to replenish their stocks. And with this, it is also a little bit more challenging because we try to replenish stocks that are used by what we call a village malaria volunteers. They are people who are based in the very remote areas, and we equip them with the test and the treatment, and they sort of look after their communities. In some places, it's working quite well. Okay, next. Yeah, this is once again about case management. I don't think we need to go through all this. For the interest of somebody who's interested in knowing what we are doing. Okay, next. Like I said earlier, behavior communication is very, very critical for us. We are trying to look for ways to improve this. Because at the moment, we're lacking in many different areas of, you know, people not doing the right things and issues like that. So we looking at this kind of communication to be able to educate people on what they should and should not be doing. Okay, next. Yeah, as I mentioned, I keep on mentioning it again, the surveillance and response is a very big area which we at the moment lack the capacity to have a good system in place. And that's one area we continue to look at to have a good surveillance and response system in place. Okay, next. Yeah, that's again surveillance. So we can probably move to the next slide. Thank you. The enabling environment is I think, is a key component of everything that we do. It means trying to develop and maintain strong layer program management at all levels, not only national. It has to filter down to provincial and maybe the district, because district is the place where everything happens, and that is the place also where the lowest educated people are operating out of. And so that building that kind of capacity is going to be beneficial for any program. And the supply and management, sometimes this is out of the hands of the program, but we do what we can to be able to ensure that our commodities are procured, the right ones procured, the quality ones procured, so that we don't have any issues with quality. And of course, we work on a 5-year strategic plan, and we plan to review this, constantly, so that it can guide us how to move forward with all these activities. And of course, the infrastructure is something that is beyond the programs mandate, but we try our best to indicate to the right people where certain things are supposed to be, so that services can be delivered. Okay, maybe next one. Yeah, here we once again, it's the enabling environment. We're talking about political commitment, financial support, uh, multi-sectoral partnerships, uh, of course, all the other stakeholders within the country and outside, internal and external technical collaborations. So these are the some of the issues that we have been looking at to ensure that we are working in an enabling environment. Okay, we can move on. I think. I put this one here just to show you how how we try to split up whatever budget we have, especially when we are doing our planning and issues like that. So, one of the biggest components is case management. Uh, and then the other big component is vector control. That is the uh, mosquito net business and all that. And so this just shows very quickly how we break up our budget when it comes to our planning for the programs. Okay, we can move on. Yes, this is the common word that everybody uses. Elimination by 2030. I don't know whether PNG can be able to achieve this. I'm optimistic. Probably we can reach some level of burden reduction, but probably not elimination. I think, yeah. Okay, let's move on. I think this is my last slide. So if you, what we have decided is if you want to do elimination, maybe the strategies we already have, we need to better it, refine it, and do it properly so that there is some impact instead of just doing those same things which have the same kind of impact all the time. So we need to tweak these strategies a little bit so that it may have an impact on how we move forward to elimination. Okay, I think this must be my last slide. Oh, now forget about this one. I'll just leave this one out. Okay, I think that is about all I wanted to present.
And what you presented, Dr. Makita, was critically important. It was a very, very important presentation to understand, to get a better picture of what's going on in your part of the world, which is a very, very important part of Asia Pacific, obviously. And I think we all have a clearer understanding of exactly the scale of the challenge that you face if you want to reach elimination by 2030. Wow, you've got a big mountain to climb to get there. So you showed some very, very interesting slides, and you made some very interesting comments. One which I found very interesting was net distribution is not a problem, but it's the uptake of those nets, the use of them. It would be very interesting to try and unravel that a little bit. Why is it a significant problem? But so, Dr. Makita, as I said, you had a fascinating presentation. I have absolutely no doubt many members of audience would like to pose questions. There are some already in the chat box. As a default, we would like to keep the questions for a general session right at the end. But I just want to ask you, Dr. Makita, are you available? Are you able to stay until the end for the collective Q&A session, or do you need to go back to your meetings? Are you able to stay with us until the Q&A session?
I can stay on. The only problem is that timing, because if I stay too long, they probably lock me inside and I sleep in the office.
Okay. All right. So,
But I'll stay as long as I can.
all right. Thank you for that. I know there are people that, as I say, there are already questions in the chat box. So if you need to go, please prompt me a little bit before so we can slot in a few questions for you. Let me ask you, I'm going to make a bit of an exception in your case, because it seems you are under a bit of pressure to go. So there were questions here from Tom Burkott to you, where he said, what do you think the impact of the low quality nets that lacked sufficient insecticide had on the increase in malaria cases? So the relationship between the proven deficiency in ability of the even bed nets distributed 6 months ago, at the end of 6 months, there's a rapid decline in bioefficacy of those nets. Do you think that played a significant role in the increase in malaria cases that you showed on your very first slide? Any comment, Dr. Makita? Dr. Makita, are you there? All right. Dr. Makita may have gone for a break, bathroom break or something. So we'll get back to him later. Let's move on to what had been scheduled as our keynote presentation for the day. But we ramped up Dr. Makita because my understanding was he's busy with very important meetings. So I thought give Dr. Makita a chance to get his presentation done with. And then we'll come to what is supposed to be our keynote presentation by Dr. Mohammed Mukhtar from Pakistan. And Dr. Mukhtar, as all of you will know, is director of the Directorate of Malaria Control in the Ministry of Health in Pakistan. Pakistan has had severe floods, as most of you will also be aware of. And of course, those severe floods translated into very significant public health issues, including malaria, and I'm sure dengue and others as well, but definitely malaria. And Dr. Mukhtar has some very, very interesting information to share with us. So we genuinely look forward to your presentation, Dr. Mukhtar. Over to you. Thank you for making time available for us. Over to you.
Thank you, Leo. Good afternoon, everyone. This is Mohammed Mukhtar. Can anybody you see my slides?
Yes, but if you can make it full screen, please, Dr. Mukhtar.
I'm making it. Yeah.
There we go. Excellent.
Yeah. Thank you very much for inviting me for this as a keynote speaker. And title of my presentation is a vector control during flood disaster event in Pakistan. I put / after flood because the real challenge start after when the flood is gone, the water becomes stagnant. Then the real challenge start for the vector control. The picture which I have shown in my 0 slide give the entire background of my presentation, that the people are living in shelters or tents, and people have no homes, and where they are living in a very poor condition, and which actually make them vulnerable for the mosquito bite. In the middle of the slide, I put a very beautiful picture of the mosquito, that is Anopheles pulcharimus. And today I will present a very interesting finding after what we have seen after the flood in the country, particularly for this mosquito. Just before joining this meeting, I sent the mosquitoes, a good number of mosquitoes to CDC Atlanta for their analysis to decide whether the pulcharimus is a real vector of the malaria in Pakistan or not. So that's why I put this picture on my 0 slide, pulcharimus, because we have some very interesting finding what we have seen after the flood. So this is my agenda for next 20 or 30 minutes. The monsoon and flood in Pakistan in this year. and then overview of the vector-borne diseases in Pakistan and vector surveillance post-flood situation, which is very important because as we all the expert knows that during the flood, the incidence of the vector-borne disease, particularly malaria, is not high. But the challenge starts when the water becomes subside and the water becomes stagnant in small pool. That's why the post-flood situation is more dangerous than from vector-borne disease point of view. My fourth agenda point is vector control under humanitarian emergencies due to flood. Because you know that in Pakistan, this is the over the last 75 years most severe flood situation in the country. That's why we call it as a humanitarian emergency in Pakistan. Then fifth agenda point is challenge and what we have lesson learned from this flood and then forward. So these are my 6 agenda point which I will speak on these points. My first point is the monstrous monsoon and flood situation in Pakistan. This is the situation you said the monsoon rains start. Just a second. Monsoon rains start normally in Pakistan mid of the August, Indo-Pak subcontinent mid of the August. But this year the floods start in the mid of this in September until mid of the October, and very surprisingly, this year we have almost 500% more rains in Balochistan and Sindh province, 400 times in the Balochistan and 500 times of percent more rains in the Balochistan. And these are the 2 provinces which are most flood affected in the country. And there are a dramatic increase of the malaria cases in these 2 provinces. And overall in country, 200% more rains in the country. Overall situation till there's a mid of this early of this September, though the figure rises that the total deaths in Pakistan till 5th of this September were 1,325, which is actually close to 1,700 till the end of the November. Injured people 12,700 people, and the road destroyed almost 6,000 kilometer road totally destroyed, and the 246 bridges are destroyed. Actually, why I'm showing this slide, because because when the roads are destroyed, the bridges are destroyed, then you have the difficulty and to have the accessibility to the target areas. That's why during this flood we have a lot of problem of the accessibility to our target areas. Overall, 1.6 million household destroyed, and we lost almost 700,000 livestock during this flood till 5th of the September, which is actually 1.1 million end of the November. So this situation shows that this is the most disaster flood situation in Pakistan in our history. The overview of the vector-borne disease in the country. Pakistan vector-borne diseases are a significant public health importance like other countries. Being a subtropical country, Pakistan has a rich fauna of the vectors, which include mosquitoes, sandfly, ticks, bugs, housefly, mites, cockroaches, which account for number of vector-borne diseases, including arboviruses. But mainly we are focusing the mosquitoes, sandflies, and ticks. Among the vector-borne diseases, malaria is a topmost with the confirmed malaria cases 400,000 annually. But this time we have reported till end of the November 1.2 million cases of the malaria confirmed cases from the country, which is the end of the till end of the November, which means that the malaria in some district, which I will explain in my coming slide, that the 20 times more malaria cases have been reported from some flood affected areas. And then which shows that the malaria is a real problem nowadays in Pakistan. And this time we are at the state of the emergency during our last 50 years malaria history. So malaria is one of the big problem after this flood in the country. Currently, vector-borne malaria, annually we have the 400,000 and 1.2 million cases suspected here. Dengue is another big problem of the country. Leishmania, which I call is a time bomb. Leishmania is normally is a most neglected disease in the country. But otherwise, because it's a disease which is in the far-flung areas, that's why it is not being, but we are now focusing leishmania as well. Then Congo virus, chikungunya, but very interestingly, what we are expecting in coming years, that Japanese encephalitis. You know that in between Pakistan and China, there's a huge road connectivity, and we are receiving thousands of the container during the trades with China, and that's why we are focusing the Japanese encephalitis, because in Pakistan, most abundant mosquito species is a Culex tritaniuranthes, Culex sodovishnae, which are actually the vector of the Japanese encephalitis. So that's why we are very much conscious about the Japanese encephalitis as an upcoming threat, as a vector borne in the country. West Nile virus, yellow fever, these are our upcoming threats. So next, no, I come to the actual agenda point of flood affected areas in Pakistan. Malaria, as I told you, that is a seasonal in Pakistan, which is mainly after the monsoon. Sporadic outbreaks occur every year in particularly epidemic-prone districts, which are mainly located with Iran and Afghanistan border. The factor behind these sporadic outbreaks are the high incidence of malaria is a prolonged drought followed by the heavy rain, particularly this year. Low coverage of intervention, both diagnosis and treatment, and low coverage of poor socioeconomic condition, particularly our bordering areas with the Iran and Afghanistan. So these are the factors which are behind the high malaria transmission, particularly in the western border with Iran and Afghanistan. And if we talk about the ratio of the falciparum and vivax, we are mainly vivax leading country. There are 76% of total cases is vivax, and 22% is the falciparum, and almost 1% mixed infection. Anopheles culeus is a major vector, supposed to be, but no, I use the word supposed to be, because in my zero slide in the beginning, I show you a picture of the pulcharimus, because this time we are facing some huge problem due to pulcharimus when we have a massive field investigation in the flood affected areas, and we see something different as we were believing previously. So Culeus traditionally believed as a major malaria vector in Pakistan. Stephen says secondary vector, mainly urban vector. It was declared in urban in 1968, but still we have some doubt. But pulcharimus, which I put some question marks. So I put a question mark here on this slide because I will speak in detail in coming. No, these are the district. Blue color shows the district which are affected by the malaria, the flood. Out of the 134 districts in the country, 60 are categorized as stratum 1, having the API more than 5, which sharing 91% caseload of the country, which means there are out of 134 districts, 60 districts are the districts which are contributing more than 90% caseload, and these districts are mainly located with the Iran and Afghanistan border. So bordering area is a western border, not eastern border. With India, you have seen that there is almost no malaria in Punjab province with the Indian border, but we have the actual problem in the western border with Iran and Afghanistan. Out of 60 stratum 1 districts, 26 districts which have been shown in the blue color are rarely affected by the heavy rain and flood, and we have the main malaria cases from these districts. Some of these districts of these 26 have the 20 times more malaria cases, and during the last 50 years, we are first time at the state of emergency in terms of the malaria incidence. Selection of these districts or declaration of the district hit by the outbreak has been based on our DHS2 data and the comparison of the DHS2 data of the 2021 and 2022, which clearly shows the heavy rise of the malaria cases in Pakistan after this flood. This is the APMEN monitor of the WHO, which you can see that the normal is the green color showing the normal caseload. Then the C show the cumulative sum of the cases of the 5 years, and then red color shows. If you see this, sorry, APMEN of WHO, this shows that we are far ahead of this this red color, which shows that the malaria cases after this flood has increased manyfold in the country. That's why we are at the state of emergency for the malaria in Pakistan. Thank you to WHO for preparing this slide for me. And this shows our national data set through this APMEN. If you look at after the week 30, which is actually in the August September, we detected the outbreak in Pakistan, and then we continuously have a huge. Actually, the blue color shows the yearly data. Yellow color shows our cumulative data of 5 years, and then red color shows the mean plus 2 standard deviation, which indicate that after the 30th week we have reported a outbreak we detected the outbreak in Pakistan after this monsoon rain. And now I come to the dengue, which is very interesting slide. I have only 3 slides for very interesting slide. I just give you the two comparison of the two scenario. In 1994, when the first time dengue was reported in Pakistan until 2003, during these 10 years, we have only 4 districts affected in Pakistan. Only 6% population was affected under the threat of the dengue. There were only 3,000 suspected cases and confirmed cases were 700. And there were only 6 deaths during these 10 years. If we move to next 10 years or 15 years, dramatically increase that the 153 districts are affected by dengue within next 10 years. 100% population at the risk of the dengue. Now you can see 16 million suspected cases of dengue in Pakistan as compared to the only 3,000. Now 16 million versus 3,000. Now confirmed cases, if you look at that we have 265,000 confirmed cases and 1,632 deaths. Now you can see the comparison of the two scenarios, which clearly shows that dengue is the most rapidly spreading arboviral infection in Pakistan. Now I go to the next slide, which is this slide is I have taken from my presentation, which shows the impact of climate change on the dengue vector-borne diseases. If you look at the both scenarios, the container index during the last 1994 to 2003, the 5 to 2 of and the average of the container index was 11, and then household index was 11, bureau index was 15, adult 3 specimen per positive household. Now, if we go to the next scenario for 2005 to 2022, the container index has increased almost double, household index exactly double, bureau index almost double, close to double, and adult population 8 specimen per positive house, which indicate that the real increase of the vector densities in Pakistan, particularly this climate change, and this flood situation is also due just because mainly with the climate change. So this again I shows that the dengue in Pakistan is also a rapidly spreading arboviral infection in the country. And you can see the distribution of both Aedes aegypti and albopictus. 2006 and 2010, the albopictus was limited to the upper part of the country, but the aegypti shows the uniform distribution of across the country. But for next 10 years, and this I have linked directly with the climate change, that the albopictus has reached in every part of the country. This really shows the impact of the climate change, and the flood is also the result of this climate change. So you can see that the dengue is the most rapidly spreading arboviral infection in the country, and the dengue vector also shows a rapid spread across the country. Now, vector surveillance, very interesting in flood affected areas. Very recently, thanks to WHO, we have a joint mission with the Directorate of Malaria Control and WHO. We visited these flood-affected areas, where we are reporting 5 to 10 times increase in malaria cases, which really demand to have a systematic vector surveillance to analyze the situation. A joint mission of Directorate of Malaria Control and WHO was constituted. 2 districts each from the Sindh and Balochistan and 1 district of Punjab were selected. Most malaria-affected localities, villages were selected or visited. Adults were collected from household, temporary shelters, and tents. So these were our strategy for vector surveillance. Results very surprisingly, results were showing that not a single specimen of Anopheles tulisiphaceae in 4 districts was recorded from the 5 flood-affected districts. This is something unbelievable for program, that the tulisiphaceae, which is a major vector of malaria, and on the other side, there are 5 to 10 times increase of malaria cases, but the actual malaria vector is totally absent from the field. On the other hand, unexpectedly, very high densities of Anopheles pulcharimus were reported from all 4 districts of Sindh and Balochistan. 90% of total reported population Anopheles pulcharimus. So total what we have collected the mosquito, 91% were the Anopheles pulcharimus, not a single specimen of Anopheles tulisiphaceae. 3% were Anopheles stephensii, and 4% were Culex mosquito, which has not been yet identified. Now you can see that when the malaria cases 10 to 5 to 10 times, in some cases, the 20 times malaria cases increase in the country after this flood, but there is no population of tulisiphaceae, then which species is spreading malaria in Pakistan? And then another interesting that out of total collected mosquito which you collect from household, 63% were collected from the sleeping room, which indicate that the pulcharimus have the indoor feeding behavior, and 13.9% from animal shed, and 30% from washroom, and 9% other places, which include barrel, drums, the other resting. Out of total collected, I just giving this statistic to highlight that we are now going to investigate the entire dynamics of the malaria in Pakistan after this finding. And thanks to WHO Pakistan Country Office for facilitating the National Malaria Control Program for having such wonderful field visit, and then we went. And no doubt, Anopheles pulcharimus has been already reported. It is not a new species to Pakistan. It is already present in Pakistan, but it has never been incriminated as a malaria vector in Pakistan. However, this species is a confirmed malaria vector in neighboring countries like Iran and Afghanistan, which indicate that this species might playing a major role of malaria transmission in Pakistan as well, because our both neighbors, Western neighbors, Iran and Afghanistan, have the pulcharimus as a confirmed vector. But the situation after the flood, when we have 5 to 10 times more malaria cases in Pakistan, the pulcharimus showing almost 90% total of the total population of the Anopheles in the field. Now, this raises some very important questions for a program. Where is tulisiphaceae, which is a major malaria vector in the flood-affected areas? Where is tulisiphaceae? But on the other hand, there are many time rise of the malaria cases. In the absence of the major malaria vector, Anopheles tulisiphaceae, which mosquito species is spreading malaria in flood-affected areas of Pakistan? Is the flood water wipe out the Anopheles tulisiphaceae, or it is just replaced with the other species like the pulcharimus? Is it a climate change which replace the tulisiphaceae with the pulcharimus? So these are the research questions which we want to answer. We want to get the answer. That's why we are investigating this situation with the help of our partners, particularly with the WHO. Is this replacement is a permanent, or maybe it's a longer period, and program could not report this replacement? I just give the example of our own paper which we published in 2004, why malaria is low in the Punjab in Pakistan. Because the finding shows that the tulisiphaceae was replaced by the stephensii, which is a salt tolerant species. So that paper is also published, and I can share with you in the group as well, that at that time we concluded that the tulisiphaceae replaced by the non-efficient malaria Anopheles species, that's a stephensii. But here we are reporting that tulisiphaceae is replaced by some other species which looks more prominent malaria vector in Pakistan. So just before this meeting, we sent to the almost 300 specimen to the CDC Atlanta of the bull carrier specimen for their analysis, for blood bill analysis, the DNA sequencing, and also sporozoite infectivity rate. So after those results, which will conclude that whether the bull carrier is a confirmed malaria vector in Pakistan, but overall situation shows that the bull carrier playing a significant role of malaria transmission in Pakistan, like in Iran and Afghanistan. So this is very interesting finding for program. If it is true, if it is proven, then we will have to change the entire dynamics of the malaria control in Pakistan, because this species showing some different habits and habitat in Pakistan. This is very important because we have also seen that there's a huge population of the natural predators. Though we have reported a huge population of the bull carrier, but we have also reported but we could not report a breeding in the flood water, big water bodies. There is absolutely no breeding of mosquitoes. Mosquitoes actually breeding in a small water pockets which are created after the flood. Why there is no breeding of the mosquitoes in the big water bodies, flood water bodies? Because there are a huge population of the natural predators, particularly dragonflies, and we have seen a huge population of the fish, gambosia, which this shows that the nature is also playing its very important role for the control of the mosquito. So after having these findings during this field visit, excuse me, we have given very strict guideline to provincial and district not to use any chemical in the flood water bodies for the further building up of these natural predators. So this is just introduction that though we have reported a huge population of the bull carriers and bull carriers, but the breeding is not in the big water bodies which is created by after the flood. Breeding is going on in small water pockets which are resulted of this flood. No vector control. Yes. What are the vector control? You know that the key in success in the disaster management speed of the response. As soon as you show the response during the disaster, like the flood, you will get the success. But unfortunately, this is not for Pakistan, but across the globe, vector control under the humanitarian emergencies like the flood, war, internal conflict is a challenging task for a country. And according to WHO, you know that there are two core interventions, that use of the ITN and IRS. And both interventions require a specific requirements like the stable structure, surfaces, proper space, logistic access to the target area. And if you look at these pictures, none of the pictures supporting the both core interventions. People are living in the temporary shelters, particularly tents. They have damages houses. They have used the bed net. If they have, the bed net is in very poor. So this is a very challenging situation, not for Pakistan. Wherever there is a natural disaster like flood, war, we are facing the vector control under the complex operating environment. So these pictures actually showing my coming two slides. This is what I'm going to speak. Other intervention like larval source management, fogging, user repellents, and donor dependency. You know that during the emergencies, countries mainly rely on the donors, are the partners. That's why there is sometimes a delay in response. Unfortunately, the national programs are not so much equipped to respond to such natural calamities. That's why there is a delay in the vector control, and then when there is a delay in vector control, the malaria and vector-borne disease incidence rise suddenly to up to many folds. So, adaptive strategy. Now, for the LLINs, during this flood, Pakistan was conducting its national LLIN campaign 2020 during these flood days, where we have almost 3 million bed nets were distributed. Addition to these, 705,000 LLIN were also distributed in the flood-affected areas in addition to campaign. But these bed net are, no doubt, we have very successful campaign. Congratulations to program, its partners, everybody who played a vital role for this campaign, and we made a very successful campaign. But we have the challenges. after the distribution of bed net. That is the utilization of the bed net. If you look at the pictures, the people are using the bed net which are in a very dirty condition, very dirty. The upper picture, right side, the very dirty condition. Bottom, you saw the picture, people are sitting in a small tent where the bed net cannot be used. So despite the fact we have a very successful campaign, and definitely we will get its impact, but still we have some challenges. And despite the very success, we have some lessons. For mass distribution, single phase. So I will not talk on this, but I will talk to the next point. The ITN should be as a relief package, because when you have the outbreak, when you have the emergencies, airline must be provided as a relief package, like the food items, so that the people are getting the bed net along with the food items. And that's very important. You know that the picture shows that the bed net which is in a very poor condition. The very important point is that no doubt we have distributed millions of bed net, but when these people will go back to their homes, they will lose the bed net. That's why the program is seriously thinking that we must have some extra bed net for those people. When they are returning to their home, they must have the bed net with them, because what they have the bed net in the temporary shelters, tents, they are in a poor condition, they are not properly used, they will lose. So things like that. So that's why the provision with extra bed net when returning home is very important. 60% population is living in the shelter building camps with the small, like a school, inns, and hospitals and tents. And I have seen the deliberately shows this picture. The people are living in tents. They are not possible to use the bed net. So that's why, despite the fact they are receiving the bed net, but still they are keeping with them, because the tent is too small to install the rectangular bed net. Then we can also show the promotion of the circular bed net. Now, after this flood, there is internationally there is a debate that the promotion of the circular bed net should be there to deal this situation. A strong BCC campaign is needed, because what we have seen in the field, people have the bed net, people have to receive the bed net. Again, that's very successful campaign. People receive the bed net, but they are not know how to use it under this condition. So that's why we need a very strong BCC campaign to tell the people to give the importance of the bed net and the malaria, and then realize them how to use this bed net under this situation. Daily use the bed net, daily sleep the bed, because the people are exposed to mosquito bite. So that's why there should be a very strong behavior change communication strategy to make the acceptable, to enhance the acceptability of these bed net. No, these are some pictures which I shown that despite the fact we have distributed bed net, but the structure of people who are living there. So these are the lesson learned that despite the fact we have very successful campaign, but the utilization rate will be a big challenge, just because of these pictures that the people have the damaged houses, they are living in tents, people are living in the shelters where in a big hall there are hundreds of people are living, and they can't install the bed net for a single family. So these are the pictures showing some challenges for the use of the bed net in Pakistan after this flood. Then indoor residential spray, very important intervention. First time in Pakistan that we are realizing that the IRS is a core intervention, and it should be used as a campaign intervention. As I told you in previous slide, if I go to the previous slide, left side upper picture, when the people are living, many people living in a big hall, they can't use the bed net for an individual family. Then we are to focus for indoor residential spray for such buildings where the people are living in a big hall where there is no space to install the ITN. So IRN should be top priority. Temporary animal sheds, because the people have the temporary animal shed, and sometimes animal shed attract the mosquitoes, and then but for the tents which we are recommending for the IRS, but we are recommending only the use of pyrethroid, because pyrethroid is the safest insecticide that can be used in a small tents. So pyrethroid is the safest. That's why we are suggesting the pyrethroid, because we are recommending the spray of the tents, because we have collected the pool carimus and other mosquitoes. huge problem for tents. That's why we are recommending with the help of WHO that the tent should also be sprayed with IRS, but only with pyrethroid, because pyrethroid is the safest chemical and the tents are very small. So that's why, keeping with the human safety, we are recommending pyrethroid. Thanks to WHO again, the WHO, with the support of WHO, we have started a systematic campaign of IRS in selected districts of the Sindh and Balochistan, which are most flood affected areas in Pakistan. We are focusing the hotspot initially where the positivity rate is more than 50%, very high positivity rate. And Balochistan is completed. Now we are going to start in the Sindh, despite the fact temperature is low, but keeping in view the high population of the vector density, we are still going on the IRS. Now we are next week, maybe this week, we are going to start our systematic campaign through WHO support in the Sindh province as well. And even from the community, there is a high demand of the IRS, the first time in Pakistan. And thanks to also the Global Fund, they first time realized that the indoor residential space should also be there parallel to the LLIN for the rapid decline of the malaria cases in Pakistan. Other vectors of the picture are not showing, but other fogging, though is not recommended. I'm going to finish my presentation. Fogging, though, is not recommended as a routine intervention, but highly effective technically and politically under the emergencies. When you do the fogging as a fogging, according to the principle, definitely it gives the impact. Normally people say it's a political weapon. It's not a political weapon. It's a highly effective intervention when you do it as an intervention, not as a political weapon. So fogging is also recommending for under the emergency. It's our national strategy that the fogging can also be done, particularly for dengue cases. Promotion of repellents, very important, particularly when you are talking about the outdoor transmission. Repellents has never been included in our national strategy, but last year, 3 years back, when we developed our national strategy plan for elimination, repellents are also giving a top priority that under the emergencies, particularly after the experience of this natural calamity in Pakistan, we are also promoting the repellents, and we are requesting the partners and the donors that we should also focus the repellents, particularly when the people are living in tents where they can't use the LLIN, where they can't use the IRS. So the repellents can be used for those, and the treatment of larval source management, no chemical promotion of the biological base, because you know that when there is a flood, we have we have to limited use of the chemicals, but biological based methods like insect growth regular BTI can be used. Challenges, as I already mentioned, this is just the repetition, that's why I quickly go to this. Vector control normally is a very big challenge always for every country. Two core intervention require the specific requirement. Particularly after these pictures showing that there is a not proper space, proper surface, proper structure for IRS, neither for the LLIN. And sometimes people misuse the bed net, which I have shown in picture. I'm not talking about the misuse, but I'm also talking the inappropriate use. When the people hang the bed net in front of their tent in open sunlight. When the bed net is in open sunlight, the insect set will deteriorate. So that's why these are the challenge for the program. Then availability is required domestic funding. As I already mentioned that under the natural condition, national program are not ready for such calamities, emergencies. So which result in the delay in intervention. Availability qualified product, because in emergencies you have to procure, and sometimes there is a poor quality of the insecticide or bed net. Misuse or improper, which has a strong coordination among the stakeholder and partner. Believe me, in Pakistan, many partners doing a wonderful job. But unfortunately, there is some gap of communication, which result in the duplication of the resources. So we recommend that this is a challenge, and then ban of the import of insects from India. Because India is our next door neighbor. Just because and due to some political reason, there is a ban on the import of insecticide from India. Though we know that the most of the WHO pre-qualified insects are manufactured in India. That's why we are debating with the government, federal government, to uplift this ban from the import of insects from India. Lesson learned. thorough review of the vector fauna of the country, because what we have seen, the bull carimus is actually vector, actually an offering species in Pakistan, and Tulisipes totally wipe out. So that's why we are now have started the thorough review of the mosquito fauna of Pakistan, exploring innovative tools for vector control. Apart from the LLINs or IRS, we have to explore the innovative tools to deal such situations like the repellents, like the other things that donor flexibility of selection of intervention, particularly in case of outbreak and emergency, because donor have a very specific principle for the LLINs, but there should be flexibility of in the selection of intervention. A strong BCG campaign, which I already mentioned, strong coordination, which I already mentioned, uplift the ban of the import of this. So these are the lesson learned and way forward, which is actually we are recommending to our government, federal government, that we will have to uplift the ban of the import of insects, because India is a next door neighbor. Cheapest insects are available for Pakistan. So that's why we are still in the process with the federal government to uplift this ban, and then use of the some other innovative like the BTI, like the other things, for enhanced use of IT and promote the conical shape of bed under the complex emergency. This is very important. We have distributed millions of bed net. The people are rate of utilization low because the people can't use in their tents. And then backup supply, when the people will go back to home, they construct it, there should be some backup supply to additional bed net, so that they can, when they go back, they can use those bed net. And when they construct new host structure, there should be IRS. So there should be backup supply in the pocket of the program. So these are the lessons learned which we got from this emergency. Believe me, this is a very big emergency in Pakistan. We are state of the emergency for last 50 years in Pakistan, when there are against 300,000 cases, we have 1.4 million cases of confirmed cases malaria in Pakistan. So these are the lessons learned that we have got from these emergencies. I think this is all about my presentation. Thank you very much. And you can see the picture. And sorry. So we must help those people. If we are the partners, we are donors, we must help these people. So thank you very much. Over.
Dr. Mukhtar, clearly your country, Pakistan, has experienced a humanitarian emergency of mega scales, mega dimension, multi-generation, once in multi-generation event, with a very dramatic impact on malaria. It seems like dengue as well, and other vector-borne diseases, aside from the other health issues that go with such a major flood. I think each of us in the audience developed a strong sense of the impact of what you've been through there. And from all of us, we show you our deepest respect for the way Pakistan has risen to the challenge. And you in particular, you and your department, Dr. Mukhtar, how you've responded to address the unforeseen, never before experienced scale of such a big problem. How you grabbed hold of the situation and dealt with it so effectively. With so many lessons learned that you can share with the rest of the world, that has to be documented, taken up and shared. So from all of us in the audience, Dr. Mukhtar, we are very grateful for the effective way you showed us what happened in your country, shared the information, fascinating facts that you shared with us there. Just the massive increases in case numbers, the shifts in vector relative proportions, and the need for good surveillance and response. So Dr. Mukhtar, greatest respect to you and your team. Well done, and thank you for sharing with us. I have absolutely no doubt there are going to be many questions from the audience. Are you able to stay with us until the end, Dr. Mukhtar, or do you need to go?
Yes, actually, we have the delegate from the Malaysia, which is to come to Pakistan for the BTI introduction. So, but for next 15 and 20 minutes, I'm here. I can, if there is some urgent question, I can respond because they are waiting for me. Actually, they have just landed today in Pakistan last night, and today we have a day-around meeting with them. So I'm available for next half an hour if there is some very urgent question.
Yeah.
Otherwise, my colleagues can also send by email. I just send my email address in chat box. So, but I'm here for another for half an hour.
All right, half an hour is not enough, Dr. Mukhtar. So I think let's try, take some questions. I see Dr. Makita also has to leave very shortly. I wonder if he's still with us. Let me start. Dr. Makita is still with us? Yes, I see his name on the screen. Okay, Wulan, do you have that table with the questions? Then we can start with Dr. Makita, because I think he's going to have to leave before Dr. Mukhtar. So let's pose a couple of questions to Dr. Makita, and then a few to Dr. Mukhtar, and then we can go to the other presentations. Okay, so a question from Dr. Sharma, Ranjendra Sharma. Dr. Makita, there's a large difference between suspected and confirmed malaria cases. How malaria elimination is possible in such situation in Papua New Guinea? The general trends seem to be okay, but there's a disturbing difference between the number of suspected and malaria. Do you want to make any comment around that situation?
Yeah, okay. That is basically because of the system we have. You see, we have a lack of microscopy stations throughout the whole country. There are only very few operational ones. This is because of many different reasons, like HR issues and all that. So that's why we have not been able to develop a microscopy stations where we wanted to. At the moment, what is happening is people are turning into rapid tests. And now, a rapid test, yes, it does give us what we want in terms of our policies where you have to treat, confirm, and treat. But having to get that confirmed data is still one of those challenges, because the issue of reporting clinical cases in many cases is still there. So no. That is where the differences come in, because we do not have a good network of confirming cases. Sorry, I opened it.
Yeah, thank you, Dr. Makita. So I'm going to jump around between questions because we can't ask all the questions right now, unfortunately. We have some speakers still waiting for their turn to give presentations. But I'm going to, here's one of Topgi's questions is, we will have to debate on, he's basically asking the question, where's the bulk of the transmission happening? Do you think outdoor transmission is a major source of infection in your situation there, Dr. Makita?
Yes, I believe outdoor transmission is probably what is happening. There may be several situations that allow for this to happen. Is because in many societies now, people are staying outdoors much later than they normally would. This is because of the advent of solar energy and all that. So people tend to sit around, watch pictures, and so basically, what I feel is that much of the transmission may be going on outside, and probably early in the evenings. So by the time you are able to get under your mosquito net, the biting periods are probably over. So, I mean, I don't have concrete proof of this, but I think that is generally what I feel is happening.
Yeah, yeah, that's thank you for that, Dr. Makita. I'm going to just ask one part of Tom Burkott's question, and it's the second question. So you made the statement in your presentation that distribution of bed nets is not the problem. It's the uptake, the use of the bed nets. And that's what Tom is getting to here as well in the second part of his question. Do you know anything about the use of nets among households that have access or actually have an ITN in their possession? Could you just talk a little bit around why is it that people that do have a bed net and they are aware of the high risk of malaria infection and the consequences of malaria infection, why is there a reluctance to use the bed nets? Just your thoughts on that, please, Dr. Makita.
Yeah, thanks. I think there are quite a number of reasons why people, do not use mosquito nets. I mean, one that comes to mind straight away is, people do not feel comfortable, especially, on the coast where it is much warmer, sleeping under mosquito nets. So, they tend to uh, ignore mosquito nets, in terms of usage. Uh, but we've got evidence to show that there is, like I said, there is no issue at all with the distribution of nets. We've reached almost the entire country. And still, we do have this increase in cases and things like that. So we've seen that the usage of these nets is not very high. We just recently completed a study with PNG Institute of Medical Research. And the ownership, or rather the accessibility, is very, very high. You can go up to about 80-90%. But the usage, when their question about usage, it comes down sometimes below 50%. And so why that is happening is something that requires a bit of work to figure out. So it probably has got a lot to do with educating people on the use of mosquito nets, the benefits of it, and issues like that. So that I believe is what is causing these issues of non-usage in communities.
Yeah. Thank you for that, Dr. Makita. So it seems that we're still not sure exactly what it is, what causes people, why there's that reluctance to actually use the bed nets. So I see the questions have disappeared. I just want to ask you one additional question. Jeffrey, he asked those questions. I'm not going to put all of them to you. It's the kind of question that we can put during the general Q&A session that other people could try and respond to too. But I just want to ask you the question. It seems that there's a rapid decline in the bioefficacy of bed nets. So that I think, if I remember correctly, the published figure that Stefan Karl and others published was even 6 months after distribution, there's a strong or a significant decline in the bioefficacy of those nets in terms of the mortality it causes on to mosquitoes that come into contact with those nets. So I think Jeffrey is asking, is there merit in conducting pre-distribution cone assays to determine bioefficacy of those nets, or some kind of assay to see what is the actual efficacy of this net even before they get distributed. So I don't know whether you have a minute that you can just say something about the potential merit. I know it's going to come down to time and staff problems and very real practical issues, but it seems that there may be a need to do at least sampling of the nets that are scheduled for distribution, just a sample of nets tested to see how effective they in fact are. Any comments, Dr. Makita?
Yes, so I was going to comment on this earlier on, but I didn't. See, we've done a lot of work on the bioefficacy of bed nets. Now, what we have actually found is that the nets that we have been using have lost their sort of bioefficacy by miles, and what is happening now is that these nets only are able to be effective for a very short period of time. I think it is something to do with the manufacturing practices. There's a lot of other things that could be causing this, but I think as a program together with WHO, we are continuously monitoring these nets, those new ones that we intend to use, and the old ones that are out in the field. So we continue to look at the bioefficacy. And we've, as a country, decided that some nets are not as good as it should be. Others may be a little bit better, but this might be very much dependent on how the nets, how the insecticide is put into the nets. So that kind of work is still going on. I think we've raised this kind of alarm to different people, including manufacturers and WHO. And we've said, this is what is happening. So what is the way forward for us to get more effective nets that actually work? Otherwise, the cost of delivery is so high. We could be delivering nets that have no efficacy. So that kind of work is still ongoing. We continue to look at what other options we have in terms of net procurement. So that is, I think, something which as a country we've raised, and
Yeah.
we still await responses from WHO and the manufacturers for that matter.
Yeah, no, thank you, Dr. Makita. I mean, these issues that you raise have been the subject of, responsible scientific tests published in international peer-reviewed journals accessible to WHO and everyone. Direct representations have been made, but an appropriate response is still being awaited. I know it's very difficult to change direction if you're in charge of a massive ship, but it would be good to see some kind of response indicating that some attention is being given to this very serious issue. And I'm hoping that my good colleague, Dr. Tinchor Thu at Global Fund, I'm hoping he's in the audience, and maybe during the bigger Q&A session, he can say a few words addressing this issue, his thoughts on the matter. But it is a very serious matter, as you point out, and it can't be swept under the rug indefinitely. Thank you for that. Dr. Makita, so thank you again for your contribution. I'm going to move on in the interests of, to be fair to the other speakers. Dr. Mukhtar, I know you also have to go soon. So I'm going to ask Wulan if we have any questions for you, then we can pose at least a few questions to you before you need to leave. Thank you again, Dr. Makita. We appreciate your time. Thank you.
Thank you very much. Yeah.
Thank you. Okay, so Dr. Mukhtar, as I thought, you've got a whole bunch of questions here aimed at you. So the question here from Mohammed Khan, where does Pulcherimus breed? What were the breeding sites that you collected them from? Or was it primarily adults who collected, or did you do larval collections? And can you say something about, I think you did mention they're not in the open, big expanses of water. They're more in confined, smaller pools.
Yeah.
So, all right. So you've addressed that question basically, but let me ask you, do you want to say anything more about that?
Yeah, I've already explained that in the bigger water bodies, which is a large stagnant water bodies of the flood, there was no breeding of any species. But the Pulcherimus and there's some other species which we collect in a minor number, like the Stephen, they are breeding in a small water bodies which have become stagnant close to the tents, close to the houses, because when water subsides and there is a small pockets of the water even in some irrigation channel or in a field, a crop like field, but it's mainly breed in a small water body which is close to the tent or houses, even inside the houses where the water was stagnant for over some period of time. So, but in a larger water bodies, there was no breeding of the Pulcherimus as well as other species.
Yeah. So similar to Stephen's eye, Dr. Mukhtar?
Yeah. Sorry?
Okay. Sorry, similar to breeding sites used by Anopheles Stephen's eye.
Yeah, same. But Stephen's eye, even very few population, very less population, but it's a Pulcherimus, and that is mainly breeding in the small water bodies.
Yeah. So I'm not going to deal with each question because we need to move on. But here's an interesting sub-question I'm going to ask you from Suvan Watal. What was the proportion of PF and PV post-flooding? Do you have that information available? Indication of falciparum versus vivax?
Yeah, I responded in chat box as well that we have almost a similar one, that 75% is the vivax and 25 falciparum. But in some districts it goes up to 30% falciparum, but it could remain close to the 70, 75 in between in different areas.
Okay, and then along the same lines, Dr. S.N. Sharma asks, mortality, percentage mortality due to Vivax in relation to falciparum. Most of the cases reported are Vivax. Any comments about radical treatment, availability, and so on?
Yeah, very good question. But because the mostly cases are Vivax, we are relying on the radical treatment. But we have only one challenge of the availability of the Primaquine. Otherwise, the other because in our treatment protocol for the Vivax, we have to treat the patient for 14 days through the Primaquine. And sometimes when the patient become a cure or recover within 2 or 3 days, he or she left the taking the medicine. So so this is the challenge for us for the treatment of Vivax.
Okay,
Yeah.
thank you,
Yeah.
Dr. Mukhtar. You made a comment about advocating rather than for chemical insecticides, chemical larviciding, rather use products like BTI. So there's a question here from Gangagarti asking, how effective, in your opinion, just your gut feeling,
Yeah.
was the use of BTI pretty effective in larval control?
Yeah, very interesting question. And with that, when I told you that there are some delegate from Malaysia in our office, which are promoting the BTI. Actually, BTI is mainly we are promoting for the control of the dengue mosquitoes. No doubt, because you know that the dengue, not in Pakistan, even in the Indo-Pak subcontinent, they breed in a neat and fresh or drinking water, where we can't use the traditional chemical like the tamifos and fenthian. In those breeding sites for dengue, even for malaria as well. We are also having some trials over the last few months. Even before the flood, we are focusing the use of BTI for the control of the larval control in Pakistan. And what we have seen, because what we have seen, it gives us some promising results for the control of the larvae in Pakistan, particularly dengue larvae, because the dengue has a very confined breeding place, and we can easily calculate the dose of the BTI and apply and because in Pakistan, as I already mentioned, that the Culex, Aedes mosquito breed in a drinking water, neat and clean water, which people normally use, and the people don't prefer to use the chemicals for those. So that's why we are promoting the BTI in the program for the control of the particularly dengue and generally for the malaria, but depending upon our field trials for the malaria.
Thank you, Dr. Mukhtar. So there's a question here about, if one has the in-country capacity to do your own assays, it was preferable to do your own assays there rather than sending the samples all the way to CDC. So perhaps just to give you a pat on the back by mentioning to our audience that very recently, in the past couple of weeks, Pakistan unveiled the absolute global state-of-the-art entomological laboratory facility, which is a very spacious, very well-equipped facility. And I'm sure that, you now have the ability to do pretty much all the assays that you would require. You can probably do in-house now, Dr. Mukhtar. Do you want to perhaps just say one or two things about that recently unveiled
Actually,
facility?
Yeah, actually, I have answered all these questions in chat box, but thank you very much, Asif, for a wonderful question. Actually, we were no doubt the in-house or in-country capacity building is one of the primary objective of the program. And as everybody knows that we have established our first national entomological laboratory in a university where we can do all these. Why we are sending these sample to CDC Atlanta for some, because it needs some high level certification. Otherwise, we are not sending all the collected mosquito to the cities. We have the specimen with us to have the same test locally, either in our national entomological reference insectary or somewhere else. So it's a very good question, and we are also building, and we have the capacity. We have the capacity, but this is a bull carimus is a something has a some higher level of certification for the its vectorial capacity in Pakistan. That's why we send some proportion of the sample to Series Atlanta for their analysis. Otherwise, we can do, and after and the one of the point with the Series Atlanta is the capacity building of the program. And after we are also going to have a capacity building with the CDC Atlanta, so that we can do these sort of analysis locally with the help of our provincial colleagues like Asif and Ajmal Khan is sitting there, and we can have the capacity, but we further want to enhance our capacity through such and collaboration with the CDC Atlanta.
Fully understood. No, absolutely understand your reason to get independent, a high-level confirmation. Yeah. Fully understand that, Dr. Mukhtar. So last question, and this is a personal question from me, and I don't take long, don't bother to give a long answer. It just reflects personal interest. You spoke about dengue vector control. So the question pops up in my mind because you didn't mention anything about it. Is the use of, for example, guppy fish or other larvivorous fish species, is that a culturally acceptable and widespread practice in Pakistan for use in confined spaces, water jars, water tanks, and so on? Or is the use of predaceous fish not really a big practice in your country, Dr. Mukhtar?
Yeah, this is a very interesting question. In 2012, when there was a huge outbreak of dengue in Punjab province, and there was a large-scale use of the mosquito fish in the open ponds, then I wrote an article, the use of the mosquito fish for dengue control. Actually, dengue fish are the effective when it is used in a confined places, not in open places. But in first time in Pakistan, where dengue was outbreak in Punjab in 2011-12, there was some huge use of and there is huge pond, and people are putting a few hundred fish in those polluted water. Then I asked that it is not the appropriate place to use the mosquito fish for the dengue control, because they need a small confined water bodies where there is no other choices of the food. Mostly, I just give the example for the lighter mood. If we go to a wedding ceremony where we have the 12 dishes, we will go to some precious dish first, and at least there is a very cheap poor food. But if we have a single food in a wedding ceremony, you will have to eat that one. Either you go back to with hungry to at your home. The same is example for the mosquito fish. Mosquito fish is effective when it has a limited choice food choices in the water bodies, and that is only in the confined water bodies, not open water bodies where there are some other delicious insects are available for mosquito fish. So this in Pakistan, no doubt is a growing culture. But we are promoting the people that it can be only used in a confined water bodies, or some ornamental vessels, or some ornamental plants, not in a big pond, because it's not an appropriate place to use the mosquito fish in a big pond.
Dr. Mukhtar, thank you for that. And from all of us again, great respect for what you and your team have been doing in the face of such a massive challenge. Congratulations to you, and thank you for taking time off in your busy program to share with us the experiences you had. So thank you, Dr. Makita and Dr. Mukhtar. We're going to move on now to our other speakers, and my apologies to our other speakers, but I hope you understand we had to give opportunity for some questions to be posed to Dr. Makita and Dr. Mukhtar. So our next speaker, our next presentation is going to be on Anopheles salivary antigens as serological biomarkers of vector exposure and malaria transmission. And this is a joint presentation by Professor Freya Folks and Ellen Kearney, and they are from, sorry, I'm jumping from one notepad to another. So Freya Folks is Deputy Program Director, Maternal and Child Health, and she's also Head of Malaria and Infectious Disease Epidemiology at Burnett Institute. The presentation, I understand, is going to be actually done by Ellen Kearney, who's a PhD candidate and works closely with Freya at Burnett Institute in Australia. So Ellen, thank you so much for your patience. Eventually we got to you. Over to you. Thank you, Ellen.
No worries. I'll just make sure everyone can see my slides correctly.
I believe I can, so I'm assuming everyone
Great.
else can. Yeah, thank you.
That's all good. Okay. So thank you very much for the opportunity to speak today. I, as Leo said, am a PhD student in the Malaria Infectious Disease Epidemiology group at the Burnett Institute. And I'm going to be sharing with you today some of the research I've been undertaking as part of my PhD, which is looking at using Anopheles salivary antibodies as serological biomarkers of vector exposure and malaria transmission throughout the GMS. So since the declaration to eliminate malaria from the region by 2030, the countries of the GMS have made significant progress towards this goal, reducing the burden and associated mortality by 80% and 90% respectively. However, as the burden of malaria declines, its transmission becomes increasingly heterogeneous and often localizes in discrete foci or hotspots. And this has pretty significant implications for the delivery of malaria control and elimination interventions, as a one-size-fits-all becomes increasingly insensitive. So the World Health Organization has therefore identified a critical need for a strong and sensitive surveillance system for malaria and its vectors, and identified this as a cornerstone of the elimination agenda, as this will allow us to direct resources to where they're most needed and ultimately accelerate progress towards elimination. However, the current tools that we have to perform surveillance for malaria and its vectors are insufficient. So I'm not going to waffle on about vector methods to a vector audience, but basically the kind of gold standard metric that we have to measure vector exposure is obviously the human biting rate. And the gold standard metric to measure malaria transmission is the entomological inoculation rate. And both of these methods require, well, the gold standard method to measure these metrics involve a human landing catch to be performed, and then with dissection of the captured anopheles. I think there's somebody drawing on my screen, but that's okay. So there are several limitations associated with these approaches. Largely that human landing catch is inherently challenging and resource intensive to perform. And also the EIR becomes increasingly insensitive in low transmission settings as the number of Anopheles infected mosquitoes, Plasmodium infected Anopheles mosquitoes are so low and often zero. So this has led to the World Health Organization make calls for novel tools and improved approaches to enhance vector surveillance capacity. So when an Anopheles mosquito bites a person, some of its saliva is injected into the human host and causes the humans to mount an antibody response. Several previous studies have explored evaluating antibodies against proteins that are present in the Anopheles saliva as a sensitive biomarker of exposure to Anopheles bites. So while several studies have employed this approach, the association between the antibodies against Anopheles salivary proteins and human biting rate in EIR, and how this association would vary according to the setting as well as the dominant vector species, had yet to be quantified. So we published a systematic review and meta-analysis last year that pulled together all of the studies that had evaluated human antibody responses to these Anopheles salivary proteins. So here I'm showing you the study-specific estimates of the seroprevalence of antibodies against the most commonly assessed antigen, which comes from Anopheles gambiae. It's called the Anopheles gambiae salivary gland 6 protein, or GSG6. So the seroprevalence of anti-GSG6 antibodies is our y-axis. And I'm showing you human biting rate as our x-axis, and that's been log transformed. And you can see that we observed a strong, positive, nonlinear association between human biting rate and GSG6 antibodies, which is suggesting to us that Anopheles salivary antibodies against GSG6 could be useful as a proxy biomarker for human biting rate. So we were then interested in whether we could use GSG6 as a serosurveillance tool for vector and malaria exposure. So despite the focus on the importance of entomological surveillance as we approach elimination, relatively few studies combine vector surveillance with geospatial and geostatistical modeling. So the kind of most commonly referred to maps come from the Malaria Atlas Project vector maps, which map the predicted probability of vector occurrence. So here I'm showing 2 of the dominant vector species of the region of Southeast Myanmar that most of my research is focused in. And I'm showing you the Anopheles minimus and Anopheles maculatus. And these are the predicted probability of their occurrence, with the red being a high probability of occurrence and blue being low probability of occurrence. And you can see that these maps don't capture much spatial nor any temporal heterogeneity. They also don't actually measure vector exposure. They don't take into account the diverse vector behaviors in terms of host seeking and host feeding, nor how they interact with human behavior. So we were interested in understanding whether we could use Anopheles salivary antibodies against GSG6 as a serosurveillance tool to measure spatial and temporal heterogeneity in exposure to vector bites, to potentially identify areas of ongoing malaria transmission or that are receptive to malarial rebound. So we've employed a geostatistical modelling framework to determine associations between Anopheles salivary antibodies against GSG6 and environmental and climatic risk factors for Anopheles occurrence. We've used these associations to generate the first predictive maps of the seroprevalence of GSG6 antibodies, and then evaluated the influence of seasonality on this seroprevalence. So we've got about 13,500 dried blood spots that were collected in 104 villages in 3 states in Southeast Myanmar, and they were collected monthly over a 15-month period. We've evaluated antibodies against the Anopheles gambier salivary gland 6 protein via high throughput ELISA. And we've employed a Bayesian geostatistical modeling framework that basically takes the seroprevalence of these antibodies against GSG6 in each of these 104 villages, incorporates them into a spatial kind of complex, and then we use this to identify risk factors and then predict the seroprevalence of GSG6 across this spatial area. So after undergoing a pretty rigorous model selection process, we identified several important environmental and climatic covariates that are shown to be important in vector ecology. And we've then determined their associations with GSG6 seroprevalence. So the main kind of takeaways of this table are that we observed positive associations with rainfall, tree coverage, and nighttime lights, which is a kind of proxy for where people live. And basically this means that the more rainfall and the more tree coverage, the higher the GSG6 seroprevalence. And we observed negative associations with the inaccessibility to cities, the land surface temperature diurnal difference, which is the difference between the day and the nighttime temperatures, the topographical slope, and tassel cap brightness, which is kind of proxy for barren areas like rocky outcrops and concrete slabs. So again, we kind of interpret this as the more similar the day and the nighttime temperatures, the less extreme the topographical slope, and the less barren an area, the higher the GSG6 seroprevalence. So we've then used these associations to predict the seroprevalence of GSG6 antibodies across our 3 states in Southeast Myanmar. So this is Bargo East, Kayin, and KR. And overall, we can see that the seroprevalence of antibodies was quite high, with a mean seroprevalence of about 62%, but we do observe some spatial heterogeneity. So we can see areas in the northern parts of Kayin and KR that have a lower seroprevalence, ranging from about 40 to 60%, and some sections kind of throughout the region, but mainly running from north to south of Bargo East, that show higher seroprevalence, ranging from about 70 to 80%. But as we had access to samples collected in each village over time, we sought to explore if we could use GSG6 antibodies to determine heterogeneity, both spatially and temporally. So we found that GSG6 antibodies were very different according to the season. with the mean seroprevalence in the hot season being around 71%, before dropping to about 36% in the rainy season, and then rising to about 85% in the cool season. So while this seasonal trend of having the lowest seroprevalence of antibodies during the rainy season may seem kind of counterintuitive, when we break down the dynamics further and look at antibody levels monthly, we can see that a decline in antibody levels occurs kind of from April through to June of our study, which coincides with the end of the hot and the beginning of the rainy season, before they begin to increase during the rainy season and then are sustained at quite high levels throughout the remainder of the study. So this is suggesting to us that we may actually be capturing a lagged effects of these typical seasonal dynamics, with the cool season potentially showing increased antibody levels generated by exposure to the bites that were occurring during the rainy season. However, we do identify that further studies that directly measure the rates at which these antibodies boost in response to Anopheles bites and how they decay in their absence are needed so that we can have a greater understanding of how we could use these antibodies to track changes over time. So to our knowledge, this is a first study to employ a geostatistical modelling framework to demonstrate that Anopheles salivary antibodies against GSG6 were associated with environmental and climatic risk factors that are proxies of Anopheles occurrence. So we've then kind of used the Malaria Atlas Project modelling framework to show that GSG6 antibodies can identify finer scale, spatial and temporal heterogeneity in exposure to Anopheles bites compared to the previous static maps that were just of vector occurrence. And this is suggesting to us that this approach could be useful to perform serosurveillance for vector exposure. And we're interested in exploring whether we can combine GSG6 antibodies with another metric as a potential way to measure EIR. So we're also quite interested in whether we could use GSG6 antibodies to evaluate the effectiveness of vector control interventions. Several previous studies have reported a kind of seasonal or intervention-induced reduction in GSG6 antibody levels, like this study here from Papadrame and their colleagues, that basically show that antibody levels were significantly reduced following the introduction of insecticide-treated bed nets. But most of these previous studies are only descriptive. They don't directly quantify the effect of the intervention on antibody levels. So we're interested in understanding whether we could use GSG6 antibodies to assess these changes in biting exposure over time in response to an intervention. So our study is of repellent, personal repellent, which we rolled out to 114 hard-to-reach villages in 7 townships in Southeast Myanmar. We collected 14,000 dried blood spots that were collected monthly for antibody determination via ELISA. And importantly, within this population, we identified a large representation of at-risk populations of migrants and forest dwellers, with the remaining participants being village residents. So we used linear mixed effects modelling to determine the associations between the distribution of repellent and Anopheles salivary antibody levels. And importantly, we found that this association was moderated by risk group, which means that the effect of the intervention was different depending on whether you were a village resident, a migrant, or a forest dweller. So here I'm showing some forest plots of the estimated mean difference in GSG6 antibody levels. And if we consider the bottom line here, it's for an instantaneous effect of repellent distribution for our village residents, migrants, and forest dwellers. So we interpret these forest plots as follows, that if the value is on the right hand of 0, as for our village residents, we interpret this as an increase in antibody levels associated with the introduction of repellent, while if it's on the left-hand side of 0, as for migrants and for forest dwellers, this is a reduction in antibody levels associated with the introduction of repellent. But as I kind of described before, we're interested in exploring the potential lagged effects of repellent distribution, as we want to be able to model gradual antibody decay that's associated with prolonged use of repellent. So by allowing for this, we observe a pattern of reduced antibody levels. So if we look at the 6 months of repellent use, we can see the distribution of repellent 6 months prior is associated with reductions in antibody levels for migrants and for forest dwellers, but not for village residents, which is suggesting to us a potentially protective effect of repellent protective effect of repellent on vector exposure for these high-risk groups. However, as the confidence intervals here kind of cross the null value of 0, the evidence for these associations are weak. So just kind of in conclusion, this study suggests to us that Anopheles salivary antibodies have potential as a logistically feasible alternative approach to measure exposure to vector bites and could be an informative trial outcome for vector control intervention effectiveness trials. However, as the evidence in our study is weak, further studies are needed. And these studies would likely need to be longitudinal in design to adequately capture boosting and decay dynamics that would ideally, and they would also ideally measure entomological endpoints such as HBR and EIR that we could directly compare against. But overall, it's quite a promising approach that may actually allow us to get better estimates of the total vector exposure that are missed by traditional vector capture methods for our high-risk populations of migrants and forest dwellers. So with that, I'd just like to thank basically a lot of people, largely my PhD supervisors and Freya, who can't be here today, and sends her apologies. But yeah, I've put my email down there as well if anybody has any questions, to feel free to reach out. Thank you.
So Ellen, this to me, and I immediately confess, this is a field I'm very ignorant in. I'm not familiar with this kind of research. But to me, this comes across as very high level, cutting edge, necessary research, very impressive and well presented, very clearly presented. Thank you for that, Ellen. Very, very interesting. Personally, I need to digest it a bit more to be able to formulate semi-intelligent questions.
That's totally understandable. That's so fine.
But I'm sure that among our audience members, there will be some questions coming your way. If you don't mind, do you mind if we wait until end of session Q&A period, Ellen, or do you have to move away as well?
What I will do, Leo, is I will monitor the chat and I'll respond to as many people as can in the chat, and then I'll hang around for as long as I possibly can.
Okay. All right. Thank you for that.
No worries.
Yeah, Ellen, very grateful for that very thought-provoking presentation. Thank you for that. Thank you, Ellen. Yeah. Okay, let's go to Dave de la Cuesta, who is head of Asia operations for DFI's regional headquarters in Philippines. Dave, you can tell us what DFI stands for, if you don't mind.
Yeah.
So Dave is going to tell us something about the role and contribution of private sector in vector-borne disease control. And I always feel guilty and a bit bad about the way we seem, the vector community tends to sideline our very important commercial partners. We talk about the issues that are at the coalface out there in the field, resistance monitoring and outdoor biting and all these very important issues. But we tend to overlook or forget about the critically important role of the private sector that makes available our key vector control tools, bed nets for one thing, but the repellents and everything else that helps us to combat the mosquitoes that transmit the malaria. So, it's very important to hear from our commercial partners, private sector, and it's great that you have made yourself available, Dave. We're very grateful for the time you put into preparing a presentation for us. So thank you, Dave, and over to you.
Thank you very much, Dr. Leo. Can you hear me?
Very clearly. Thanks, Dave.
Perfect. Perfect. Thank you very much. And thank you for having me. It's a pleasure to be here. So as Dr. Leo mentioned, I'm here to talk about the role and contribution of the private sector in vector control. When I was brainstorming the flow of the presentation today, I thought, what we'd like to do today is to focus on three main things. Number one is to revisit again, as Dr. Leo mentioned, the importance of the importance of private sector engagement and the benefits of doing that. Second, I would like to review a little bit on the various models of the private sector engagement that's been present in Asia Pacific over the years that we've been working together. And then towards the latter part of the presentation, I would like to share an update on the recent Rollback Malaria Partnership meeting. There was a meeting held last October 18, and it focused on the private sector models that they've been doing there in Africa. And I thought I'd like to share that with you to spark some brainstorming also, right? To see if we can perhaps adapt or replicate some of that in the Asia Pacific region. So all of this is meant to just share information and see if there's any models we can explore in Asia Pacific moving forward. But before we do that, maybe allow me first to just introduce myself and my company. The DFI, as Dr. Leo mentioned earlier, stands for Development Finance International. And DFI is a consulting firm. We've been working for 30 years, and we are headquartered in Washington, D.C. in the US. But we also have an Asia office here in the Philippines. I'm based in Manila, Philippines. What we do is we help private companies develop public-private partnerships. So you see there, the model of collaboration that we have is to create a model in which all stakeholders benefit. So it's a collaboration between the private sector, funders, government, stakeholders, and NGOs. So the reason there's a finance in the name of the company is because we help, bridge projects to get to donors, for example, such as the World Bank, or here in Manila, the Asian Development Bank, among other donors. Of course, there are different donors in every sector. So you would see there some of the private sector partners or clients that we have across sectors. Of course, health is a big priority for us, and one of our main partners is BASF. BASF, you may have heard of them. They are one of the manufacturer of LLINs, and recently they have established also a new partnership together with donors that I'd like to share with you as an example, just to show with you, the type of work that we do. BASF is one of our partners, as I mentioned. So recently, with the demand for new tools, right, to address insecticide resistance, they have developed a new LLIN. It's called Interceptor G2. It's a second generation net. Basically, it's a dual AI net. It has a pyrethroid insecticide, but also a new insecticide called chlorfenapyr, which is a totally different mode of action to pyrethroids. And through because there's a need, right, we consulted stakeholders, and eventually they launched a partnership together with UNITAID, the Global Fund, USAID, and including some additional private sector partners like Bill and Melinda Gates Foundation, to fund the research and development for this project, and also to fund the pilots. So at the moment, pilots are being done in South Africa, in the Southern Africa continent, including Rwanda, Burkina Faso, Nigeria, among others. And then next batch will be in Liberia, Ghana, and Malawi. So it's really a multi-sectoral approach. The ministries of health are together with us in this, and as well as the donors. So you see here, in the launch meeting, it was Bill Gates actually who also presented the solution to the stakeholders in the meeting, both in 2018 and 2019. And I heard just yesterday that the policy recommendation for this from the WHO is expected Q1 of next year. So we will keep you informed on that once that's available. So that's just an example of a multi-stakeholder partnership in which governments, private sector, and funders are all collaborating in one goal, in which is to create new tools for malaria control. All right, so moving on, enough about us. Moving on, again, I would like to just review briefly what we know about private sector engagement. I think it's been emphasized in several meetings, right? Why it's important. First, it's important because, for us to achieve malaria elimination by 2030, it requires doing more beyond, right, business as usual. So it involves extending to partners, including private sector companies, to help bridge the gap in many ways. One way is, of course, through funding, right? As of 2020, it's been estimated that about $3.5 billion of funding gap is present for malaria control. That's the gap between the funding available across all donors and governments and the need, right, for interventions to address malaria. Second, private sector companies provide additional bandwidth, right, for treatment, diagnosis, and surveillance for malaria control. So they add additional resources to the programs. And then lastly, new tools, again, as I mentioned earlier, as an example, are needed. So they also can provide tools in a collaborative manner that address needs. For example, in Asia Pacific, outdoor transmission is a big need. So there's a lot of focus being put into that. In terms of examples, what we've seen over the past years, there's been many attempts to really bridge the gap with the private sector, and I'm actually encouraged by that. There are some challenges with sustainability, but at least the effort is there. With funding, the Global Fund actually reported that they've accumulated $3.6 billion of contributions from the private sector and NGOs throughout their lifespan. So that's a lot of funding that they've leveraged. In Asia Pacific, there was an effort several years back with a group called M2030 that catalyzed funding from the private sector to help contribute to the Global Fund. Latest replenishment by the Global Fund, one of the M2030 partners, Ms. Duong from Vietnam, actually pledged $1 million of in-kind contributions to the program, to the Global Fund, as part of that effort. And then Rotarians Against Malaria is another example. They're very active in the Pacific. In PNG, for example, they're one of the main actors there in vector control. They have, in their most recent Global Fund replenishment meeting, they have committed about, I believe, about $4 million, for almost $5 million, $4.8 billion of contributions to funding. So it's very important that private sector is really involved in the process. That's an example on the funding side. In vector control, we've seen many examples. One is here in my home country, the Philippines. Filipina Shell Foundation, or Shell Foundation, has been active in the malaria control since 1999. And they have implemented a lot of interventions. They've been actually the recipient of the Global Fund program here in the Philippines as an implementing partner, and they're doing all the vector control, IRS, a little bit of IRS, but mostly LLI and distribution in the country. And I think we've progressed significantly in the malaria elimination goal through their partnership and participation. More recently, we've heard about the Vector Toolkit project co-funded by UNITAID, Australian DFAT, together with IVCC, and together with other partners, UCSF, among others, to help create a new vector toolkit for Asia Pacific. We've heard in the presentations a few weeks ago with the PACMOSI project, the BITE project in the GMS region. So there's been a lot of attention to that, and that project helps to hopefully introduce new interventions, including spatial repellents and other interventions to the vector toolkit in Asia Pacific. Another good example is the VCAP, vector control platform for Asia Pacific. It was launched several years ago, and it was meant to help facilitate the regulatory process for some of these new innovative technologies. So there's been attempts to that, and I'm actually pleased with the level of effort. Hopefully we can sustain a lot of these. Of course, there are challenges year to year, but hopefully, with enough attention, all of these are continued and we can replicate similar initiatives in the region. Similarly, in the treatment and surveillance, there are many governments and institutions that are trying to proactively involve private sector. For example, in Nepal, they launched a private sector engagement guideline, and I believe they piloted it in 2021 across several provinces. And the goal there is to help private sector treatment facilities with training, supervision, and as well as IT solutions to help them feed into the database for malaria, for example, diagnosis and surveillance. Likewise, a PSI, one of the NGOs working in the GMS region, together with the Global Fund and other partners like URC, is also helping pull in the private sector, especially the private clinics, treatment facilities into the malaria program. They have started in 2017, and I believe they have supported about 25,000 private sector providers over in testing over 3.5 million suspected cases of malaria over a 3-year period. And right now they're doing another phase 2 of that program. So all of that is very encouraging. So all that to say, there are very different ways and means to engage private sector, and I hope we can continue to explore all of that in all ways, in funding and vector control, as well as the broader surveillance and treatment engagements. All right, so I've shared with you what we've seen in Asia Pacific. Now I'd like to share a little bit of the updates from malaria and from the Africa region. As I mentioned, last October 18, there was a special meeting convened with the RBM Partnership to End Malaria. So just a quick background for those who are not very familiar. RBM Partnership to End Malaria is the largest global platform for coordinated action towards malaria across the world. It has over 500 partners, and of course, APMEN and APOLMA are proud partners as well into this initiative. There are 3 working groups in RBM partnership for vector control. So one is focused on core interventions. Another group is focused on increasing the vector control toolbox, similar as what we're doing here in Asia. And then the third one is implementing global vector control response. Interesting enough, under the first group, under the first work stream for core interventions, there's specific focus really. Task 3 under work stream 1 is focused on private sector involvement in capacity building and localization. And this is meant to capacitate more private sector companies and governments to help bring on more private sector counterparts. It's a 3-hour meeting. I've shared the link here in the presentation to the full session. It's a 3-hour session. It's available online. You can review the presentations there. It's a 3-hour session as mentioned. But more importantly, I've actually spoken to the organizer, Ms. Jessica Rockwood. She's the moderator of this group. And I'm proud to say she is a former also director of health here at the FI, and she's a good friend of mine. I reached out to her and told her that I'll be sharing the presentation here, and she said, please feel free to reach out to her for, if there's any interest for collaboration or if there's questions, and if there are clarifications, she'll be happy to connect us with any relevant partners in the RBM community. So with that, I have 3 slides to share. And again, I'm synthesizing 3-hour sessions, so please bear with me, but I'll try to be as concise as possible. So basically in the meeting, last October 18, there were 3 countries that presented: Ghana, Nigeria, and the DRC, Congo. And they all presented the partnerships that they have with private sector, the strategies they implemented, the successes that they've had, but more importantly, the lessons that they learned. So in all of these 3 countries, I'll share with you the summary, and I've also provided links to the presentation, the full presentation here for your reference. You can please feel free to review them after the discussion, and I've also provided some of the contact details there as available. So first is Ghana. Ghana's been collaborating with a private company called Anglo Ashanti Gold. It's a mining company, and they've started a malaria program mostly because a lot of their employees are being affected by malaria cases. So they're experiencing lost time and employee absences. And I thought that was important to highlight. And when discussing this with private sector, it's also important to highlight why it's important to them. And I think this is one of the case studies or one of the business cases that's highlighted. It's important to share that with them so that they understand the need, right, to support. And they've been supporting the Ghana program with IRS spray. They cover about 150,000 houses every year, and they're protecting about 1.2 million people with vector control, including LLINs, BCC, surveillance and treatment. So that's the private sector program. In terms of the Ministry of Health, this is the strategy they are implementing in encouraging more private sector companies. So what they're doing is they're mapping, they're doing a private sector map. So they're across the value chain of malaria and in the communities, they're mapping which private sector companies are present in that area and what's at stake for them. Is it, are their employees being affected, for example, or are there is there alignment with their businesses and the malaria stakeholders involved? So that's the first step that they're doing. Once they have mapped the private companies, they talk to them and they empower some of the companies who are already willing to do their own vector control activities. They empower them by providing capacity building and training. But more importantly, on top of that, they are currently, just this year, they've started talking to their legislative branch to propose a tax incentive for companies who are trying to support the malaria effort. They have, according to them, good support, but it's hopefully it will pass through the legislative process this year, and next year there will be active examples or activities as a result of that new law. Of course, CSR and urban area projects are typical models for engagement, so they continue to do that. So in terms of results, they've had very good success. I think Ashanti Gold has been working with them for over 15 years, so it's quite a long program. And they have seen a reduction of malaria cases by over 74%. More recently, they have also secured pledges from new companies. One is a new mining company that has pledged about $450,000 US, which is significant in new mining sites. And then a very interesting model that they are doing also is tapping bilateral donors. So GIZ, as you mentioned there in the slide, is a German bilateral agency. They provide donor funding as well. And what's interesting is they provide matching grants. So what that means is when private companies pledge donor funding, a bilateral donor also matches that with equivalent funding as well to double basically the program. So in Ghana, they're tapping GIZ to match the grant under a program called Develop PPP to match the grants from the private sector. So they're catalyzing the funding from the private sector to get additional funding also from bilateral agencies. In terms of lessons learned, they shared that really, private sector engagement guide or plan is very important. They also highlighted the fact that it takes, of course, time and it's a slow process, but more importantly, ministries or government agencies need to account for a budget also. It takes budget and time to do that. If, for example, they mentioned if they need to travel to meet a company, for example, that requires time and effort. So in fact, this year they have explored having a dedicated staff, just to focus on creating partnership with private sector companies. So that's a lesson learned for them, and they plan to continue that moving forward. In terms of next steps, they're finalizing concept notes and new pitch materials for new companies across the value chain. As I mentioned, there are very different companies in every step of the way. So the pitch material will be different depending on the company. And of course, they plan to share the materials that they have to the broader malaria community moving forward. So that's Ghana. Again, the presentation links are there for more details. And I can connect the stakeholders here as needed moving forward for Ghana. Next is Nigeria. Nigeria, the government lead is, of course, the National Malaria Elimination Program in Nigeria. They're collaborating with a group called Corporate Alliance on Malaria in Africa. It's called CAMA for short. CAMA is a coalition of private firms. They've been active for 15 years. And some of their members include Chevron, Lico Dangote Foundation, ExxonMobil, Bayer, Nigerian Breweries, Festigard, among others. And they do all of the activities for malaria control, including vector control, training, resource mobilization. So in Nigeria, the Ministry of Health, also similar to Ghana, have established a private sector desk. They are currently developing a PPP IRS business case. PPP is short for public-private partnership. It's a modality in which a government agency will contribute um, uh, resources together with the private sector partner. And the private sector partner can either also contribute resources or be a partner in the implementation of the project or of the vector control activities, for example, providing logistics or the actual manpower to do some of the vector control activities. They are in collaboration with Kama, they are creating a partnership matrix similar. It's like basically also like a mapping exercise for the private sector companies. So in terms of impact and successes that they've had, they have catalyzed resources from Lico Dangote Foundation for over 8,000 LLI. I think this is just for this year. So this is not for the whole program. It's just for just a recent update. And they are treating over 45,000 people with full course anti-malaria medicines. They are currently exploring a new partnership with a Nigerian liquefied natural gas company in one state, so they're continuing to hopefully expand the program. And in terms of lessons learned, I think one of the main highlights is really the need for a more coordinated response. I think they have done a good job in catalyzing interest and energy. I think the next step for them is to really have a coordinated response so that, for example, when private sector companies do their interventions, for example, it can be done in the same timeline, for example, or but just across in a more coordinated fashion rather than in silos. So that's the next step for them. And continue to develop the PPP business model for the companies. In terms of ways forward, as mentioned, they're trying to harmonize the efforts across the private sector companies and also trying to create incentives for the private sector to deliver projects on time and within budget. This is in regards to their PPP modality there in Nigeria. So that's the brief summary. Again, the links to the full presentations are there, both from the private sector side and also the government side. All right, and then lastly, from the Democratic Republic of Congo, they are collaborating with a mining company called Tenge Fungurai Mining, TFM for short. TFM is the largest private investment in the DRC with over 380,000 people in their communities. Before their intervention in 2006, there were no vector control programs in the region. And over 60% of the medical visits in those areas were related to malaria before their participation. So since then, they've, of course, invested a lot in IRS and NLI and distribution, larva source management and treatment and surveillance. So they're the main partner of the DRC. As of 2021, the DRC government is trying to expand this successful collaboration to more partners. So they've started to create a roadmap for the integration of private sector facilities and their HMIS, and they're starting to invite them into the meetings for malaria. But in the meantime, the partnership with TFM has been largely successful. They've reduced malaria prevalence by 66.7% up to 2019, and it's still going strong after 16 years. So I think that's a theme that we've seen throughout 3 countries. All of the private sector partners have been long-term partners, which I think is encouraging, but at the same time, I think it challenges us, right, to create new ones or to replicate this long-term successful partnerships. In terms of next steps for them, they want to create a PPP model to again invite more companies, but also at the same time, I think there's TFM has been candid to say that it's been becoming more difficult for them to sustain the program. So they're trying to explore additional ways to tap additional funding. For example, I mentioned earlier the bilateral example, because there are increasing challenges in the market, and also they're experiencing insecticide resistance in the DRC. So we're trying to explore new modalities or new interventions for vector control. So they're continuing to do that in the Congo, but they're optimistic that the partnership with TFM will continue for many years to come. So there are the details for the contacts. And again, I'm happy to create connections with Jessica Rockwood, the director for or the lead for private sector engagement with the RBM and Malaria Partnership. And yeah, that's I hope that was helpful. And again, I hope we continue to push the agenda for private sector participation and engagement here in Asia Pacific. Thank you very much.
Dave, we are grateful for your time and putting together that those examples from Africa, but you know, and our audience is primarily Asia Pacific. But I think there were some lessons or examples that are useful. So thank you for that, and we acknowledge and pay respect for the role that private sector plays in disease control, vector control, and the support that we need from private sector and that we get from private sector. So thank you for that, Dave. We really appreciate your time and contribution. Thank you. Thank you for that, Dave. So we move on to a very, very important aspect now, you know, that it's not good enough just to, the fight against malaria is not done and dusted once you've reached the point of no more local transmission and you're registered by WHO as having achieved local elimination. There's still a long road ahead to ensure that you maintain that status. And there's a lot of resourcing and work involved in maintaining that status. So, you know, there are some shining examples that we can learn from. One of them is Sri Lanka. So we have the privilege of having Risinta Premaratne. Dr. Premaratne is a technical officer for malaria at WHO Southeast Asia Regional Office. And you're going to give us a presentation on Sri Lanka malaria elimination and prevention of re-establishment. Very valuable experience, lessons learned, and practices that we can all learn from, because those same issues all of our countries in Asia Pacific will be confronted with, and we will have to deal with the same challenges and problems. So we listen eagerly to you and tap into your knowledge. Thank you so much for making yourself available, Risinta. We appreciate it. Over to you. Thank you very much.
Thank you so much. Thank you so much, Leo. It's so nice to see you. Okay, I'll quickly share my screen here. Can you all see the slides?
Yeah, if you can just make it full screen, please, Risinta.
Yeah, how is it now?
Perfect, thank you.
Excellent. All right. So let me first of all say that I'm not an entomologist by training. So therefore, in this presentation, I'll be concentrating on the malaria elimination efforts in Sri Lanka from broader perspective and going beyond the entomological surveillance and vector control perspective. And at the outset, I should be thanking my colleagues in the anti-malaria campaign or the National Malaria Program for all their hard work to ensure that Sri Lanka achieved malaria elimination, as well as thereafter, until now, sustained the malaria-free status since 2012. So let me quickly go through this presentation, but first of all, let me take a few slides from our slide desk at the WHO, which talks about the surveillance systems in elimination settings and the prevention of re-establishment. We talk about malaria surveillance systems in elimination settings as should be capable of having early detection, diagnosis, and treatment of all malaria infections, and then investigation of all the cases to determine the likely location of infection, and also going through the case classifications, then investigation of foci to determine causes of transmission and develop a focused response plan, as well as implement the focused response. Now, this is exactly what was done in Sri Lanka, although during that particular period, when Sri Lanka achieved malaria elimination during that time, these kind of guidance, the beautiful guidance that is available now by the WHO, which was published in 2017, was not available during that particular time. But basically, we would see that it was more or less the same things that were conducted in Sri Lanka as well. So when we are talking about surveillance, case detections, notifications, passive surveillance system, a country should be having a fairly wide, comprehensive passive surveillance system. All suspected cases should be tested, and then active case detection to complement your passive case detection, reaching hard to reach areas, borders, high risk occupations, and migrants altogether, all the vulnerable populations. And then once positive cases are identified, they should be notified, they should be treated, and then other response plans have to be mounted accordingly within the shortest possible time. So going further on that, I have, as I said, cases and foci to be investigated and responses to be mounted promptly. And also to support all these activities, there has to be trainings provided to different cadres of health staff, including entomological staff, as well as parasitological related staff, and so on. Now, when it specifically comes to vector control in elimination, these are the WHO recommendations. I'll be quickly moving into the Sri Lanka scenario, but just these are the kind of salient points that I want to highlight here. So universal coverage for all populations at risk, either through IRS or LLINs, then high coverage and to a high standard. And then also in areas with ongoing local malaria transmission, universal coverage has to be with effective malaria vector control that has to be pursued and maintained throughout. Not recommended are not to basically kind of duplicate or combine the interventions, but at the same time, we'll have to keep in mind that there will be specific demands, specific situations where specific complex situations you might need to combine also if it is very well justified. But then in routine, of course, we are not combining the interventions. And then, of course, we shouldn't be, once eliminated and when areas become malaria free, there shouldn't be scaling back of vector control in areas where transmission has been interrupted without a detailed analysis. So this, therefore, all these kind of specific guidance have been followed in Sri Lanka during the elimination as well as prevention of re-establishments. So how did Sri Lanka ultimately achieve malaria elimination, and what is it doing to maintain it? I'll be concentrating on the time period until 2016 because I'm not qualified enough, kind of, since I'm no longer working for the malaria campaign in Sri Lanka. So since 2016 or 17 onwards, it should have been better be presented by my colleagues over there. But I know what has been happening over there, which is a continuation of the same things that were carried out in 2006 until 2016. So a little bit of history, which is relevant to our story here. This graph shows since 1911 to 2021 or 2022, we would say, of what happened in Sri Lanka. You would see that there have been huge outbreaks in Sri Lanka. For example, 1935 outbreak, which killed more than 80,000 of the population in Sri Lanka, which came to over 1.5% of the population in Sri Lanka during that time. Now, with all those major blows within the country, still Sri Lanka managed to reach near elimination targets, especially supported by the 1958 malaria eradication drive within the world. And then they reached just 7 years in 1963 near elimination level. Out of these 17 cases, 11 were imported. There were just 6 indigenous cases during that time. Everybody thought that Sri Lanka would have eliminated malaria during that time. Everything got relaxed, and the program also started relaxing. Nobody gave any prominence to malaria any longer within the country. The result was in 1967, there was malaria came back, and then when that occurred, for the next few years, there was a huge outbreak which accounted for more than 1.5 million cases within the country. Ever since then, for the next 5 decades, malaria was having its toll on Sri Lankan population until the recent success was seen starting from 1999. Now, what is noteworthy to state here is that Sri Lanka was fighting a war since 1983 until the war ended in 2009. So it was a 30-year-long conflict that was happening, and during which time malaria elimination successes were seen. So this is kind of an example for the other countries also, that if you apply your interventions properly and if you stick to that, of course, assisted by many other I would say other complementary activities, still success can be achieved and so on. But I don't want to go into details at this point since my time is limited. So this is the progress of shrinking the malaria map of Sri Lanka. And to say that specifically when it comes to Sri Lanka geographically, two-thirds of Sri Lanka are malaria endemic zones. And this would be basically superimposing on the conflict districts in Sri Lanka where the war was fought. And the highlights and lessons from Sri Lanka's success until it was eliminated. I have listed out here the most salient ones, most key activities that were ultimately contributed towards the elimination of malaria in Sri Lanka. The country had a surveillance system in the elimination phase and the POR that was of high standard. All suspected cases of malaria received a parasitological test. Diagnostic testing was subject to quality assurance and quality control. Reporting was rapid and complete. All cases and foci were fully investigated. There was strengthened parasitological surveillance for active case detection combined with rapid response. Strong collaborations, of course, resilient health system in Sri Lanka, and strong will to eliminate malaria backed by country ownership and dedicated leadership. When I'm talking about leadership, it's not only political or whatever I'm saying. This is technical leadership as well at all levels, administrative and technical leadership, and then support for funding along with a very strong monitoring and evaluation component. I have to reiterate here, when we are talking about the global funding, people say that's a lot of funding and all that. What I really liked in the GFATM support was, it was not only the funding that was there, but there are very strong monitoring and evaluation component, which kept the national program, the director, as well as the entire staff members on toes all the time. If you allow that monitoring and evaluation to happen, take place, that of course that would be benefiting for the countries and so on. Although as national programs, we might not like the way we are being monitored and so on. Now, I was talking about the conflict zones. You would see these are the locations of last Vivax foci in Sri Lanka between 2011 and 12. I want to specifically concentrate on these areas because this is going to be very critical for the countries which are near elimination, how to ultimately wipe out the last foci that will be there in their respective countries and so on. So here you would see that they are in specifically located areas and kind of spread across certain areas where there will be malaria-free areas in between and so on, which means you really needed a focus or foresight approach during that time. Now, during that time, since the war was nearly ending, most of the cases that were seen in Sri Lanka were among armed forces. You would see in this graph that the background, the shade that is there is basically the percentage of cases that were there among the armed forces. And in front you would see the number of cases among the armed forces, the dark color, and the ash colored the small piece or the bars are about the civilians. So you would see that 80 to 90% of all the cases were always among armed forces, which necessitated specific activities to be conducted among the armed forces. Now, why I'm saying this is that if you really analyze epidemiologically your cases and the populations at risk and so on, you would specifically identify where you should be targeting all your intervention. So this picture necessitated in Sri Lanka very concrete action to be taken among armed forces. You would see that I'll be going into all these details in my next slides. But when those actions were applied in 2010, nearly 500 cases among armed forces in Sri Lanka during that time, which became less than 100 or around 100 cases immediately next year. That was thanks to all the activities, specific activities that were carried out with the help of armed forces in order to reduce the number of cases among them. So what was these cases specifically during that particular period? It was seen that since they were majority of them were vivax cases among the armed forces, among the reported cases, 55% of all cases were relapses. And it showed that usually index case, now these are specifically within the camps, which were located inside the jungles where Anopheles mosquitoes were pretty much prevalent. And so when there were cases or clusters of cases that were reported during that time within these camps, the origin of those clusters were almost all the cases were relapsing cases. Therefore, there was a need to address the relapsing cases during that particular period of time. Now, our regional malaria officers, they specifically during that period identified where the clusters are or the foci are, specifically mapped them, and then mounted a response to them. Now, during the war period, it was not possible for the civilian malaria campaign official or the workers to go and then operate in these areas because the armed camps or the army camps were not allowed to be infiltrated as such. Therefore, the activities necessitated to be introduced to within the armed forces, and they had to be trained on specific activities of malaria control. These are examples of such events where ultimately malaria control personnel specifically training the army soldiers on activities for vector control and even for larviciding and so on within the jungles where the camps are located, how they continue to do. This is some of the anti-malaria campaign workers who have gone into the jungles and then near the camps who have been carrying out these activities and so on. Spraying operations and then larviciding operations. Then these are parasitological screening of members in the camps and so on. I should be really thanking my colleagues, the regional malaria officers who have shared these slides with me. And then impregnation of bed nets within the camps. And later on, of course, these are the screening programs that were carried on, and especially the mobile malaria clinics that were carried out throughout the country in order to identify as well as to prove just before in order to support the fact that there were no ongoing malaria transmission within the country. So, in fact, I forgot to mention here that by 2012, Sri Lanka had come to the so close to malaria elimination, where ultimately by June 2012, the last case of malaria was reported. So therefore, Sri Lanka eliminated malaria in 2012 and then maintained malaria-free status for another 3 consecutive years. By 2016, it was at the end of 2015, they were eligible for WHO certification, and by September 2016, they got the WHO certification as a malaria-free country. Now, when specifically coming on to the entomological surveillance activities, all the surveillance methods that have been discussed during this, during the deliberations over here, these were conducted in Sri Lanka. Cattle baiter hut collections, cattle baiter net collections, then landing catchers, hand collections, and so on. So all those activities were carried out within the country. Now, to say that entomological surveillance is a very strong component of Sri Lanka's anti-malaria program. Now, a little bit about the collaborations that the country had, or the anti-malaria campaign had. You would see here that there were within the Ministry of Health collaborations, beyond the health sector, then within the government sector, Sri Lanka Navy, Sri Lanka Air Force, Police, Sri Lanka Prisons, Army, Ministry of Defense, and so on, Ministry of Foreign Affairs, Department of Immigration, Airport Aviation Authority, and so on. So there were so many government or state-owned sector that was involved in the operation of malaria elimination within the country. Beyond that, of course, all the private sector, INGOs, and so on, and then even religious organizations. Now, some of the examples of or outcome of these collaborations, you would see these are the collaborations with Sri Lanka Navy. This was a news item during that period. Sri Lanka rescues 138 stranded on sinking boat. Obviously, anti-malaria campaign during that time, the moment some news item comes up in the evening news, on TV, on radio, they knew that the moment something like this happens, now in this particular instance, 138 Bangladeshis and Myanmar nationals. We know that Bangladesh and Myanmar are highly endemic for malaria. Therefore, if people have been rescued by Sri Lanka Navy, obviously then they will be brought to our shores or Sri Lanka shores, which means then there will be a risk, if there were cases among them, a risk of reintroduction. This was in 2013 after Sri Lanka became malaria free, so or rather eliminated malaria. So then immediately a response was launched within the country to send the teams to where these people were brought to the show, and then and there to screen them, as well as thereafter when they were in immigration camps to repeatedly screen them just to see whether there were cases. Again, similar instances where Sri Lanka Navy apprehends 54 Indian fishermen and so on, the same kind of response. Then clusters of Vivax malaria cases that were reported among Pakistani immigrants in Sri Lanka. And this was in 2013, 14, during that particular period. There was an undocumented kind of influx of immigrants or asylum seekers within the country. Over 1,000 immigrants were screened through repetitive regular screening sessions. I'm not going to go into the details because of the time constraints, but there were 23 Vivax malaria cases that were identified among them. And the collaborations were such that these cases were identified through collaborations with religious organizations, because none of the authorities within the country were aware of the presence of these people. I'm just giving some examples here. You would see now these data have been taken from Sri Lankan the UNHCR office in Sri Lanka. Undocumented migrants who have been there in Sri Lanka by 2013, 1,489 and so on, and from which countries they have been. So we managed to screen all these, although they were not getting reported to the authorities as such. As I said, through the collaborations we had with this, the CBOs as well as religious organizations, not organizations. Sometimes it was just a leader of let's say a church that we managed to reach them and so on, then make sure that ultimately they were all screened, and then Sri Lanka was it was made sure that Sri Lanka is malaria free. These have been published in papers, and therefore if you are really interested, the whole stories can be read in these publications. And also because we saw that there were many instances where ultimately once malaria had been interrupted, or local transmission had been interrupted within the country, since we knew that the only possibility that the country could be getting malaria would be through imported malaria, we established specific collaborations with these organizations. One example is the establishment or the collaboration we had with the UNHCR. So when during the war period, when people left the country, lived in the other countries, they were returning after the war, and through the collaboration of UNHCR, when they were to be brought to the country, UNHCR would be specifically informing the anti-malaria campaign and tell us about the particular the aircraft they will be coming in, along with a list of all the people who will be coming in that aircraft, which allowed the National Malaria Control Program to screen them at the airport itself, as well as thereafter follow them up in respective regions once they went back to their original places of stay. So this continued until, and it was made sure that ultimately none of those individuals who returned to the country gave rise to any transmission within the country. But illegal migrant routes, I'm not going to go into the details as such over here, but then still, if you want to read about all these examples from Sri Lanka, this would be very interesting articles that are there about these stories, how these people ultimately illegally try to migrate to Canada through Africa and so on. When they get stranded in Africa, they get infected, and when they are brought back to the country, the kind of collaboration that was there through the collaboration we had with the International Organization for Migration, where they also will be giving us all the details about the people who we brought to the country and so on. Internal migration, similarly, how it was tackled within the country with the makeshift clinics that were conducted within the jungles itself. So these are the examples that you can, if you are interested in reading further. Lastly, a few specific points I wanted to, in fact, for the benefit of everybody. I'm finishing, just 2 minutes, and then. No, thank you. Sorry about that. Yeah, so I just wanted to tell about when we are talking about whether elimination could be costly and so on. When we talk about the finances, just wanted to show this comparison. 1989, you would see that it was quite a lot of money that was spent, but this over here, proportionately, it has been shown how much of money had been spent on insecticides, ITNs, and spraying material. Nearly 68% of the money during in 1989 went for insecticides, vector control methods, and so on. Whereas in 2010, you see that it was only 18% or 19%. So you would see when you are reaching elimination, how much you will be saving for the country, and how ultimately how this money can be utilized for all the other interventions as well as for other diseases. So here you would see how ultimately the population protected by IRS during between 1995 and 2015, when you are moving towards a focal approach, foresight kind of management, how ultimately you can reduce the use of IRS, and how you can save money with a lot of benefits financially as well as to the environment and so on. So then thereafter, it was basically making sure that to identify the imported malaria cases as quickly as possible. These are some of the examples of IEC material produced in Sri Lanka, specifically targeting those who are coming from the other countries. And however, risk of malaria resurgence is very much there. Sri Lanka is a tropical country throughout the year. There is no seasonal change as such when it comes to the ecology as such, although there could be a seasonal pattern in the malaria incidents in the past, where there is very high receptivity because of all these reasons that have been listed out. And also there is very high vulnerability as well due to migration and all the examples that I have shown, which means the malariagenic potential within the country is extremely high. And so all the credit should go to the anti-malaria campaign and the staff who are keeping Sri Lanka malaria free until now, nearly for 10 years since the malaria has been eliminated within the country. Why this time they have been successful is because of the lost opportunity in 1963 and how similar it is thereafter. The second opportunity Sri Lanka had since 1999 to 2012, how this has been basically superimposition of these two time periods. And what really happened in 1963 onwards and is visible here, and that is what Sri Lanka wanted to prevent in 2012 onwards, and they successfully did it by eliminating malaria by 2016, and hope this evidence as well as this experience is going to be helpful for the other countries for their elimination efforts as well. Thank you so much for listening.
Thank you so much, Dr. Premaratne. Incredibly valuable lessons learned there. I mean, I think it's dreadful, the example of Sri Lanka coming so close in 1963 to zero local transmission, and then massive resurgence, which is a major lesson to other malaria endemic countries. That you need to press on and persist to ensure that you reach the last case, and then the critical importance of strong vigilance to ensure no importation. So to Sri Lanka, our hats off in great admiration and respect for what Sri Lanka has managed to achieve and maintain. And clearly you had a role in that, Dr. Premaratne. You played a role, you were part of that process in earlier years. So congratulations to you as well for participating in what was a major success. And thank you for sharing all those lessons with us. I think you can stop share screen. There we are. So we come now to a question and answer session. Unfortunately, most of our previous speakers have left because we've gone over time now. We're well beyond the anticipated time for this last day of the annual conference. So I'm going to ask, we'll only deal with questions to Dave de la Cuesta and for Premaratne, Risinta. And so let's see if there are any questions for, okay, here's one for Dr. Risinta. think it relates to, it's from Dilruba Kabir. Dr. Jacinta, can you please explain the reason behind so many relapsing cases? And presumably that's, I mean, that must be due to Vivax cases. And Vivax, of course, has the problem that, you have an overt case and then you treat it, but you're only killing the parasites in the blood, in the bloodstream. And you have residual parasites still in the liver that are released subsequently and cause a relapse. So, but is there a particular reason for the high numbers of relapsing cases that you might say something about, Dr.
Sure, surely. Yeah, thanks, Dilruba. Yeah, there was a specific reason for that. In fact, as I showed you during those last stages, majority of cases were among armed forces. These were the soldiers who were fighting a war and who were in the front line. They would be getting exposed to malaria there. They would be getting infected, and then they would be coming back. But once they fall down with fever, then thereafter they will be sent back to their respective the camps. And then once they are in the camps, when the treatment is given, usually the practice was, if you are having fever, then you will be given the treatment and then you will be released from there on medical leave so that they can go home. What happens is, these people, soldiers, they will be taking the initial treatment, that is chloroquine will be taken, maybe first few doses of primaquine, but then once things improve, when the symptoms and signs, clinical features improve, then thereafter they would not continue the full course of primaquine, especially when they go home. So this was detected, and when so many relapses were there, then it was blamed on compliance issues of primaquine or the radical cure. That is where I told you that there were specific interventions that were carried out after identifying the issues. So when it was speculated, when it was seen as happening, what happened thereafter in 2010 was that all those people who got malaria, they were not allowed to go home. Instead, they were kept in barracks and they were asked to consume primaquine for 14 days under the direct supervision of a higher official. So that is where you started seeing immediate drop in the number of cases from 500 odd cases, which became 100 cases the next year. Those 100 cases ultimately became 23 cases thereafter. So it was rapid progress ever since the correct interventions were applied. This is why I'm saying that in your respective countries also, do your analysis properly, identify the reason. If there is, even after you have applied all your interventions, maybe that you have a very high coverage of LLINs, maybe you have done your IRAs. If your numbers are not going down, before jumping into a conclusion of outdoor transmission or whatever, look at the whatever the deficiencies of the interventions you have already applied. It's easy to blame submicroscopic malaria infections or outdoor transmission and so on, where we will be not having many tools to particularly address as such, whereas there are easy ways to tackle with other gaps or the lapses that are there. So that is why a proper epidemiological technical analysis is really needed, especially during the elimination phase. Thank you.
Jacinta, very, very clearly explained your whole presentation, just a good holistic approach, clearly explained, nicely contextualized, just a really great presentation and a very useful, glimpse for our Asia Pacific countries, what lies in store for them, what they need to think of, what they need to keep in mind, what to expect. So very useful information you provided there. Thank you for that, Jacinta. Much appreciated. So what I'd like to ask is, I think, Wulan, I think we're going to, there's a short poll, if you don't mind, our valued audience members, just a short poll, if you wouldn't mind just ticking the boxes. It helps APMEN understand, where we can improve ourselves or what we can do, other things we can do. So I'd be very grateful if you can just upload this QR code, which will open up the I think it's a Microsoft Forms page, and just tick the boxes. Thank you for that. And while you're doing that, again, we're at the end of our 3-day conference now. It's been a wonderful 3 days with many excellent presentations. Thank you to all our presenters. Thank you to our audience that had the patience. You've been sitting here for almost 3.5 hours now, and we're very grateful for your persistence. And then I'd also like to thank, in particular, our backroom technical team, Dr. Popo Aung, Wulan, and Dr. Porn Sihain in Singapore. Thank you for making sure that there are no technical glitches, everything on track, and that the conference proceeded uninterrupted. To all of you, one and all, it's been a great conference, and it's your participation that made it possible. So to our speakers, our audience, our support team, sincere thank you to all of you. And we'll see you. We're having another APMEN Tech Talk on the 6th of December. And that Tech Talk is going to be the thematic catch-all phrases. Should we be concerned about simian malaria? So it's going to be talking about, we're going to have several talks on Plasmodium knowlesi and all the other non-human primate malarias, the vectors, the distribution, incidence, and so on. Promises to be a very interesting webinar, 6th of December, and it'll be 12 noon Bangkok time, 1 p.m. Singapore time. To all of you, again, thank you so much, and a good day to you all.